السلام عليكم عبد العزيز، قلقوا الكاميرا لو سمحت. السلام عليكم دكتور علاء. هاي دكتور فيني سراف. This is محمد خطاب.
Hello.
ازي حضرتك دكتور شريف؟ Hi, how are you?
I'm fine. You can hear me?
Yes, I can hear you well.
Yeah,
and
that's
I'm
fine.
happy to have you between us. Really, I think it will be a fruitful cooperation in the near future between the Egyptian Scoliosis Society and the Graz Medical School in Austria.
Yeah. So I shall be hello. I shall be loading my lectures when I have them.
Yes, I will introduce you at the time of the presentation.
Yeah.
And then you will share your screen as we did before in the meeting with the Egyptian Spine Study Group.
Yeah. So I just have to share the screen and then you give me the rights to scroll.
Yes.
That's right.
Thank you, Dr. Vinay, to be a part in our activity.
It's my pleasure. It's my pleasure.
It is really something very beneficial for us. Thank you so much. دكتور علاء، ازي حضرتك؟
كيفك؟ اهلا وسهلا، شو اخبارك؟
دكتور علاء خلاص يعني بقيت عالمي ما شاء الله. الاكتيفيتي بتاعتك افريقيا واسيا ما حدش عارف يلاقيك بعد كده يعني.
الله والله انا لولا الكوفيد انا عندي هلا في شهر 9 باي ذا واي انا يعني حاحكي في شهر 9 احنا عندنا ذا فيرست بلندد ليرنينج كورس فور لاتين امريكا فور بيدياتريك سباين في شهر 10 حيكون، وانا هعمل هاندز اون في نيكاراغوا في شهر 9 a whole week of scoliosis and we are planning to do also يعني كمان حنعمل blended learning course for Central Asia أذربيجان أوزبكستان هدول يعني يعني بقينا نشتغل blended learning courses for a month or something. ازيك يا شريف؟ شو اخبارك؟
وحشني جدا يا علاء بيه، وحشني جدا.
انتوا وحشيني جدا، انت ومحمد والجميع، انتوا اخوه طبعا وزملاء
بيت الكوفيد وسنينها يعني.
الله يقطعها والله.
لولا كده الواحد كان يعني نفسي اسلم عليك بس على الاقل والله.
الله يخليك، انا بتشرف فيكم والله، وانا سعيد دايما اني اشارك معاكم في اي نشاط يعني الحقيقه. شو اخباركم؟
دايما وجودك بيسري اي مكان والله يا دكتور علاء.
الله يخليك، الله يبارك فيك، تسلم الله يبارك فيك، شكرا جزيلا. انا اللي بتشرف دايما اني موجود معكم والله.
دكتور علاء انا بعت لحضرتك على الواتساب.
نعم.
بعت لحضرتك على الواتساب فويس نوت، يبقى اسمعها كده.
اهي.
اعمل بقى ميوت ولا
اوكي. بدك اسمع شيء محدد يعني ولا كيف؟
لا انا كنت بس هقول لك هنمشي الويبينار ده ازاي، يعني الويبينار ده هيبقى ماشي ازاي؟
اللي بدك اياه.
هو احنا هنبدا هقدم الاكتيفيتي، وبعد كده حضرتك هتقدم جيسون وجريجوري ورون، وبعد كده بروفيسور يسري هيقدم حضرتك، وبروفيسور وفا وبروفيسور صغير، وبعد كده هقدم انا مهدي باسي ودكتور فيني سراف، وبعد كده حضرتك تقدم كل النادي، وبعد كده دكتور شريف هيقدم وليد النواوي ودكتور فراس الحسباني.
طيب اوكي تمام. طب انت اوكي فاين، بس بدي كلمتين على رون. الله يخلي، هو في هاليفاكس مش هيك؟
بالظبط.
بروفيسور بهاليفاكس؟
بالظبط.
هاليفاكس يونيفرسيتي؟
في كندا.
تمام، ماشي الحال يا سيدي.
ماشي الحال، شكرا يا دكتور علي.
حبيبي، شو اخبارك انت؟ كيف صحتك هلا؟
الحمد لله الامور تمام.
استقر الوضع، ما في كومبليكيشنز من وراء الكورونا معك؟
لا الحمد لله الدنيا تمام زي الفل الحمد لله.
طيب الحمد لله تمام. احنا ممكن نعمل جوينت اكتيفيتيز يا محمد في المستقبل، لاني انا تشير تبع السباين كوميتي. ما هو انا شغلي هذا من خلال اني تشيرنج سباين كوميتي في السيكوت، وبالاضافه اني البريزيدنت هلا الكت، وهلا في شهر 9 حصير البريزيدنت تبع الدبليو او سي. فهذه الاكتيفيتيز بنعمل، فاذا حابين ممكن نعمل جوينت بروجرامز.
طبعا يا ريت
لانه قاعدين هلا انا يعني هلا والكورنيل خلص ثبتنا البرنامج تبع الكوسكسا اللي هو Southern Eastern African countries. صار كل سنه. هلا السنه الجايه في كينيا مثلا حنعمل على المينيمال انفيزيف تكنيكس ان سباين سيرجري.
طب خلاص يعني ما فيش مشكله، خلينا نحط على الاجنده كده ونعمل كوبريشن سوا، ودي
بنحكي
حاجه جميله.
الموضوع بالتفصيل ان شاء الله في المستقبل. انت هلا صرت سعيد مبروك، صرت رئيس الاي او سباين ايجيبت شابتر، مش هيك؟
الحمد لله الحمد لله.
الف مبروك. خلص يبقى بنعمله من خلال رئاستك للاي او سباين ايجيبت شابتر.
والله يعني دي بوابه.
ولا انت السكوليو، مش فاهم انا السكوليوسز ايجيبشن سكوليوسز سوسايتي هذه غير عن الايجيبشن سباين سوسايتي.
بالظبط.
Egyptian Scoliosis Society دي non-profit organization founded by Professor يسر الهواري سنة 2002. يعني يعني بقى لها هي اكتر من
20 سنة تقريبا.
19 20 سنة هي. يعني ليها فممكن ثرو اتس يعني عندنا كل الاوبشنز المتاحة.
تمام ممتاز.
والميزه في الايجيبشن سكوليوس سوسايتي ان هي يعني السكوليوس فيري فليكسبل وبنعمل اللي احنا عاوزينه كله، مفيش تعقيدات اللي
خلاص يبقى بحكي معكم از ايجيبشن سكوليوسس سوسايتي على جوينت بروجرامز ممكن نعمل شيء يعني ان ذا نير فيوتشر. انتوا عندكم نشاطات معينه غير السكوليوسس ويك؟
بنعمل الايجنج سباين في شهر يناير.
هذا من زمان. هذا
ريجولاري بنعمل الايجنج سباين زي ما حضرتك عارف، حاجه انترناشونال يعني بيبقى فيها
عارف.
والسكوليوزس ويك يعني every 6 months عندنا الاكتيفيتي دي. بسايد بقى ان في اكتيفيتي صغيره اللي هي وش كان بيران يعني على اساس ان هي يعني كده كويس يا دكتور علاء.
هلا سمعتك.
بقول لحضرتك اكتيفيتي زي لوكال سيمينارز، اكتيفيتي في المستشفى، حاجات زي كده يعني.
ما بتعملوش شيء مع السودان، مع ليبيا، مع دول ثانيه؟
ريجولار لا، بس احنا عندنا كوبريشن مع السعود سباين سوسايتي، عندنا كوبريشن مع الجوردانيان سباين اند بين مانجمنت سوسايتي، بنتعاون مع توني تنور الاي ام اس انترناشونال ماسكولوسكيلتال سوسايتي، بنتعامل مع الاي او سباين. كل دي اكتيفيتي ليه.
تمام ممتاز. يلا تسلم ايديكم.
هو فعلا فكره ان احنا ندخل على افريكا is important فعلا.
الحقيقه انت عارف دكتور شريف، احنا عملنا يعني انا تفاجئت، انا يلي مخطط للموضوع انا تفاجئت. قلنا نعمل بلندد ليرنينج كورس، بس بصراحه والكورنير ريحتنا قد الدنيا. يعني الفاسيلتيز والادمنستريتيف فاسيلتيز وكذا هايله كانت طبعا من خلال السبورت تبع ويل كورنيل نيويورك وروجر هارتل. بس تخيل لما انا كنت اتمسخر اقول احنا في دولنا ما بنعرفش نلم 3 دكاتره، شايف على كيف مع بعض على ترابيزه. فقلت لهم كيف حنلم 14 دوله افريقيه، دكاتره من 14 دوله افريقيه، تبدا من السودان لحد جنوب افريقيا استثناء جنوب افريقيا. والله تفاجئت انه 37 دكتور من 13 دوله افريقيه شاركوا بشكل شهر، يعني 3 اسابيع واحنا متواصل، عارف على كيف. وهلا قاعدين بنعمل every third Sunday من every month continuously بنناقش حالات سكوليوسس قاعدين بيعملوها او they are facing ومش عارف ايه وكذا. والله انه هايل يعني، كانوا ممتازين.
دكتور علاء، طب ازاي يعني
احنا ممكن ننضم ازاي؟
بالظبط، يعني ازاي دي معموله على مستوى افريقيا ومصر مش فيها يعني؟
لا ما هو الكوسكسا في، انا اقول لك هي من خلال مؤسسه الكوسكسا. الكوسكسا از الساذرن ايسترن افريقيا. عارف البورد العربي هم عندهم بورد للكوسكسا، ده بيجتمعوا مره في السنه امتحان لكل ال 17 دوله، منهم السودان، بس مصر مش منهم لانه ما تعتبرش ساذرن ايسترن افريقيا. يعني هي السودان، جنوب السودان، كينيا، تنزانيا، زامبيا، موزمبيق، رواندا، بوروندي.
دكتور علاء طب بس يا ريت تبعت لي الكونتاكت بتاع التشيرمان او البريزيدنت بتاع الكوسكسا دي.
ما هو انا اقول لك كيف،
انا اقول لك لان مصر لازم تبقى موجوده.
لا ما انا خليني اقول لك، هي القصه انه كان رئيس الاورثوبيديك فيها من تنزانيا، وانا صرت فاكولتي ممبر، يعني بمتحن الناس فبيعملوا once per year. هلا انا ممكن احكي مع الرئيس، انا اوريدي رايح على كينيا في شهر 9 في شهر 10 معزوم من الكينيان اورثوبيديك اسوشيشن، ورايح على تنزانيا عشان نعمل 1 ويك شو اسمه. فانا ممكن احكي لك امهد لك الموضوع مع رئيس الاورثوبيديك في الكوسكسا، انه يحكي معك على اساس انه اذا في جوينت بروجرامز او كذا مع الايجيبشن سكوليوسيس سوسايتي. شو رايك؟
اوكي ماشي الحال.
It would be great I think.
خلاص بص
طبعاً.
احنا عشان بس يعني نخلي الكلام ده نعمل له ويبينار تاني، نبقى حتى نعمل ويبينار مع دكتور علاء ودكتور يوسف يبقى معانا.
نعمل اجتماع نقعد نحكي فيه محددات حتى انتم
بالظبط.
عارفين انت وانا بالعكس، يعني انا سعيد للغايه انه مصر تكون موجوده طبعا.
ديفنتلي ان شاء الله. خلاص احنا ان شاء الله
محمد ده الصوت عندك مش حلو، خد بالك.
هغير الكمبيوتر، ومين وايل ايه يعني 10 دقائق كده وندخل على طول ان شاء الله. اوكي
انا هحكي مع الدكتور. Hey Greg, how are you? Good morning.
Hello, how are you? This is evening for you, isn't it?
Yeah, it's an evening for me. Actually, it's 6:45 now. You are in Seattle, in that's right.
Yeah, it's 9 o'clock in the morning here.
Yeah, it's 10 hours difference. How are you doing?
I'm
Great
very
to
well,
see
thank
you.
You too. How is your conference going?
It's going fine. Actually, I'm really happy that I cooperated with you about the pulmonary function in the children, and now we had actually an activity, a blended learning course for Southern Eastern African countries, 14 African countries, with under the umbrella of Will Cornell, which was great for us.
Great.
And now I'm going to Tanzania for a hands-on course on scoliosis, and I'm always talking about your protocol for how to assess the lung function for children, and this is the most important thing to do, and we must be aware about that and these things.
Well, I'm glad it's working for you. Thank you very much.
Thank you very much, and maybe I might need your assistance on sometime in the near future in a webinar or something, talking about that to our colleagues in Africa, if that's
Sure.
all right with you.
I'm happy to do it. You know that.
Yeah, I know. And actually, we are doing a blended learning course also for Latin America in October this year. Are you fluent in Spanish?
I am not fluent in Spanish. My Spanish is terrible.
Because they wanted to do it in Spanish, so as you know, the Latin American doctors will be fine with that. But I need your advice always about these programs, Greg.
Well, we keep learning. You know that. We have new data all the time. So
Yeah,
I hope to give you some new tools to use in the future.
yeah.
We've got
Thank
some
you
very
very much.
exciting things coming on.
Hi, Ala.
أهلا يسري. How are you?
Hi,
ازيك?
how are you? Fine, thank you. How are you and the family?
We are all fine, and I'm stuck because of the COVID restrictions. I just traveled 2 times. It's nothing in comparison to my activities.
You cannot cross Europe.
Yeah, that's right. Actually, we are having a congress in Hungary this September. I'm not sure that I can go there or not until now.
Oh, shit.
Yeah,
I
the
was
CCOT. The
I
CCOT.
was in
anyone-
Montenegro like a month ago, and there was nothing. Everything is lax there. Pubs and restaurants are open, so it's as if there is no COVID there.
Wow.
A typical Mediterranean country.
Yes.
Relaxing too much. Welcome to our world.
So, whom do we have now?
We have Dr. Jason Chung. How are you, Jason? Jason is associate professor in Hong Kong, and he will begin actually presenting his cases, since in Hong Kong it's midnight now, I think. So we need to decrease the burden on him.
Okay. Hi, Jason.
Hi.
Good to have you.
Thank you. Is it all right for me to not stay after my talk? I can leave you alone for another 2.5 hours, or New Year's is 3 hours.
So what do you think, Yusri? Do you suggest that we might, if somebody has a questions for him after his presentation, because 3 hours, it will be 3 a.m. for him?
Okay, all right, we can do so.
Thank you.
Actually, Jason is one of our members in the CCOT Spine Committee. Also, he's an active young man, and he's having great experience in the magic rods.
Very good. All the people I knew from Hong Kong are very active, and they are unique and excellent. Starting from Hudson and John O'Brien worked there, and Jesse Long, or All Day Long, as they used to call him. So nothing new from Hong Kong. They are all bright and working very hard.
السلام عليكم دكتور يسري، ازي حضرتك؟
اهلا محمد، ازيك يا حبيبي؟
الحمد لله، ازي حضرتك؟
الله يسلمك.
هو يعني بس بعد اذنكم انا 5 دقائق هنشغل سمول فيديوز كده، 2 أو 3 دقائق حتى، وبعد كده قبل ما نبدأ بدقيقتين ممكن نتكلم تاني. ماشي الحال؟
اتفضل.
ماشي، شكرا. اتفضل يا عبد العزيز، شغل الفيديوهات اللي انت عاوزها.
لازم تجيبوا كل كتير، مش لازم تجيبوا جوج عزيز معاكي. انت بتجيبي ايه؟
دكتور علاء، دكتور يسري.
محمد.
اعتقد بقى ان احنا دلوقتي يعني بالظبط دي او نبدا ان شاء الله.
Okay. So Ala will moderate.
Yes, we'll start the moderation by introducing Jason Shong and Gregory Redding and Ron El-Hawari.
Okay, Ala, are you ready?
Yes.
Okay, we can start now.
Welcome everybody to this wonderful congress that we are having Scoliosis Week with Dr. Yusri El-Hawari, the president, and Dr. Muhammad Khattab and Dr. Sharif Al-Ghamri. We'll talk about early onset scoliosis and the updates in that, and we will begin with Dr. Jason Chung. He is an associate professor in Hong Kong, and he has great experience in MCGR, and he'll talk with us about the Hong Kong experience in the AMCGR. Please, Dr. Chung. You're muted.
The organizers for inviting me to give a talk on the Hong Kong experience with the magnetic controlled growth rods. And no disclosures. So as we all know, MCGRs has been in use for just over a decade. There is exponential interest in this technology. 163 articles can be found on PubMed, but 120 of them are actually published in the past few years. We ourselves have over 40, sometimes now more than 50 cases with mean follow-up of more than 6 years since our first publication in the Lancet back in 2012. So the outline of this talk mainly going to be talking about some benefits of the MCGR, potential uses, and also some complications that needs to be attended to. First, let's talk about some basic information about the MCGR. They come into two rod types, the standard or the offset. Depends on which direction you want the distractions to occur. This image here will be two standard configuration, and it's more powerful. But generally, we try to do a standard and offset like this so that you can actually differentially correct the spine based on either distracting one side of the rod or the other. Now, for monitoring distractions, we have developed this ultrasound technique so that we can avoid too much X-ray exposure. So this is done every month when we do our distractions, as compared to the X-rays, which we only need every 6 months just to assess the overall alignment. So we assess the housing unit. Okay, so you can see here the A to B. This is the distracted portion that's coming out of the housing unit where the magnet is. And you can measure this every time in your clinic after distractions. And we've shown that it has very good correlation with the X-ray measurements. It is also quite easy to use. So after a couple of months of training, you can probably do this with excellent accuracy. So let's talk about an ideal case. So this is a young girl with a morphinoid. So you know if it's ligamental laxity, the patient's curve is quite mobile. These are best cases for using the Magit. So this patient had a failed bracing and the subsequently implantation of dual rods at 7 years old. As you can see, we generally try to use an MIS approach and use a subfascial rod. We use this chest strain to actually thread the rod in unsubfascially. This really helps with the surgical feasibility. So you can see with every distraction, you see the extended portion of the rod extends, and this patient has quite good balance and curve correction. We've also showed with our case series that 3D changes are also good. The axial control of the spine is relatively satisfactory. There are also other techniques you can use for different kind of cases. So this is a case of thoracic insufficiency syndrome, and it has been shown to even increase the spine and also lung volume in these cases. We've also used it in a case of a severe deformity. So this is a patient with NF, very severe curve, as you can see here. And we implanted the rod onto the concavity, and with daily distractions, we were able to get quite a gradual correction of the deformity, more like an internal halo device kind of thinking. And subsequently, we do a minimally risky surgery with just basically an in situ fusion, just to prevent cord signal loss. But this is not a all rosy technique. Okay, we'll talk about some complications. Okay, as with all growing rods, there may be some complications such as infection, PGK, and adding on, but more focused on related to MCGR. I will talk about a couple of things that we've found with our long-term follow-up. In general, the complication rate is actually not low, comparable to traditional rod, with nearly a half of their patients at the early fault requiring an unplanned operation. So just quickly about the issue PGK. This is quite common even in magnetic rods when we're not distracting in such a big intervals. Okay, this is one patient with a conversion, and you can see here there is loosening of the implant proximally with a spontaneous spinal fusion. We find this more often in patients with NF, it seems like. So this is a patient with proximal anchors. You can see here, gradually it cuts out with further distraction. So this occurs even with the magnetic rod. We feel like the biggest reason is probably because we flattened the sagittal spine with this really rigid segment which you cannot actually bend, because that's where the magnet housing unit is. So unfortunately, you would flatten the spine, and there's a gradual sagittal forces that will lead to flexion forces that will lead to a pull out of the proximal anchors. As you can see here, we had to revise this case in the end. So let's talk about some MCGR specific complications. Now, very simply, if you're a new user to the technique, you need to be very careful because, as I mentioned, there's a standard and offset rod. If you're unwary about the direction of the distraction, you may actually cause problems. So you can see this is the arrow direction in which you should place the rod, and that's how you distract, and so the housing unit comes out from below. If you flip this around, you are actually unable to distract it by placing the magnet in the conventional manner. They do have this in a brochure, so I think nowadays is you shouldn't be, if you read it carefully, you shouldn't have this problem. Rod fractures, we have had a couple in the past. I think nowadays with the new welding technique, this is less common, but still possible. So especially in these cases where we keep these rods in situ for many years before removal or final fusion. As you can see here, there was a lot of metallic debris. I'll talk a little bit more about that in the later slides. Failure of distraction does occur occasionally. There are multiple reasons why this may occur. So this is one case of NF. We put in dual rods and it stopped distracting after the 8th lengthening. And actually, when we remove the rods, we see that there's actually a lot of bone formation at the extended portion of the rod. And this is probably the reason why it limits distraction. Law of diminishing returns and also clunking are two specific problems that occur in magnetically controlled growth rods. So clunking is when you have a difficulty in distraction and you feel it. This kind of clunking motion when you're actually using the external remote controller. In this study, we looked at a couple of factors that may actually lead to this problem. Okay, this is quite a busy slide, but in general, early onset of clunking usually happens when patients are heavier, with bigger body size, and if the magnets are quite close together. This means that actually you're unable to impart a very strong force onto the magnet, and this leads to difficulty in distracting the rods. Law of diminishing return has been presented in the traditional growth rods, and because of autofusion, there's difficulty in distracting these rods with the same amount as you do in the initial post-implantation. And we found that this actually may occur as well as a magnetic growth rod, but to a lesser degree. So these are some graphs showing you the lengthening of the left and the right rod, and we find that there's a mismatch between the extended and achieved distraction length with each and every distraction, and that usually occurs after clunking. But we found that after you remove the rod and in place a new rod, that actually diminishing gain returns to normal. So it's possibly due to some of the forces that limit amount of normal distraction. All right, this has been shown in biomechanics study in which the rod lengthened, you don't actually impart enough force. And we've shown that with each rod exchange, you may still have a reduction, but at the baseline, the amount of length gain remains the same. There's another issue with chronic use and clunking, which leads to erosion of the threads inside the extended portion of the unit. So you'd see this is a case after use, the rod actually bends. This is crooked rod sign, which we termed 1 or 2 years ago. When we take out the rods, you can see a lot of wearing, and you can see a bend in the distal portion of the rod. We look at the threads itself, you can see that there are actually a lot of erosion that can be seen within the internal screw after breaking apart. Metallosis may or may not be a consequence of this. Okay, you can see here in the intraoperative final fusion, you can see a lot of black debris that we excise, right? Also along the rod. So this is likely caused by some of the internal metals that are within the rod. And we've shown that in these cases, there's a lot of different types of metals. Firstly, on the histology, you can see a lot of chronic inflammation, macrophage infiltration, you can see here. And when we look at the metal content, you can see that there is a lot of different metal debris, especially a special type of metal called neodymium, which is present in magnets. And that the long-term implication of these, we're still not sure. Finally, we talk about graduation. So we published our long-term follow-up series. There's also obviously 3 options. You can do a final fusion with implant removal without fusion, and implant inside you, just leaving it inside. We found that actually some of our cases are possible to have rod removal without fusion. So this is a 17-year-old girl. At the time of maturity, we were able to remove the rods, and up to 2 years of follow-up, there's no rebound in the curvature. So in some patients who may be a little bit stiffer, you may want to consider just removing the rods. So in summary, this is a breakthrough in early onset scoliosis surgery. We do find similar results overall in traditional growth rods and maybe less complications overall, but there is definitely some specific complications you need to be aware of. There's still a lot of questions and future directions that we need to bear in mind. First of all, we don't know what is the best distraction frequency. We do need to look at the traditional growth rod and magnetic growth rod directly to see what the benefits. There are some issues with cost and health-related quality of life. We don't know exactly which is superior. And the long-term implication of metallosis and what to do at graduation still is unanswered. Thank you. I'd like to thank the organizers for inviting me to give a talk on the Hong Kong experience with the magnetic controlled growth rods.
Thank you, Jason, for your wonderful talk and the experience in Hong Kong. And because Dr. Chung it's 12 midnight in his time, so I think it's very hard for him to keep until 3 a.m. for questions and answers. So we might have 5 minutes for questions for Dr. Chung before he leaves, if anybody would have any question about the presentation that you have done.
May I start, Dr. Ala? Hi, Jason. Thank you for being part of our activity. It is a great honor for us. Regarding the rate of distraction as a temporary rod, you did the release, you did the screwing, and then you use the magic rod as temporary distractor, internal distractor. What is the rate of distraction? and how to decide that it is enough? For how long you leave it inside?
So the two scenarios, if you meant the severe deformity case, we based that for that case, so we basically implanted the rod and then distracted them daily. So every single day we distracted 1 millimeter. And we were a bit worried at that time because that was kind of the first case. We didn't know how much the patient can tolerate. So we just did 1 millimeter per day. And subsequent to that, I think she tolerated quite well. And after 1 or 2 weeks, we increased it to 2 millimeters per day, and she was able to tolerate. Once we got the curve to be around 60 something degrees, we decided that was a good opportunity for final fusion.
Okay, good. In your cases, I saw that you use a lot the cross link. Why?
Yeah, so I think we did the cross link in the earlier cases, but I think nowadays we probably don't put them in anymore because the main thing is if you put the cross links, that you may have a limitation in where you're able to do some differential correction. Nowadays we don't put any cross links in because we feel like the anchor is pretty strong. Originally we were worried about the fusion rate at the anchor spot, but nowadays I think you don't need to put any cross links in. Those are more of our earlier cases.
Okay, thank you so much.
Is there any last question for Dr. Chung before he leaves and we introduce our second speaker? All right. Thank you, Jason. Thank you, Dr. Chung, for your wonderful talk and presenting the experience of Hong Kong. And I wish you a good night and a good night's sleep now.
Thank you.
Thank you very much for your participation. It was great. So I'm very happy to present Dr. Gregory Redding, and Dr. Redding is a pulmonologist. He's a pediatric pulmonologist, but he's an icon in pulmonary function in scoliosis patient. And I was very happy. Beside, of course, his publications, he kindly accepted to participate in a chapter of a book that we have done about early onset scoliosis in low middle income countries. And he's a professor in Seattle in USA, and he'll talk about pulmonary problems and management in early onset scoliosis. Greg, thank you very much for your participation.
Well, thank you very much for having me. And I want to thank the organizers for giving me the opportunity to speak. My talk today, my topic is pulmonary issues related to early onset scoliosis. This is a broad topic, but I hope to cover some high points as we go along. Let me see if I can advance this. There we go. So I have no commercial disclosures to make. And I'd like to start with this. So we know that pulmonary impairment in children with early onset scoliosis and spine and thoracic deformities has been assigned a fairly vague term coined by Dr. Bob Campbell, and that was thoracic insufficiency syndrome. And this is not a structural definition, but really a functional one, which is important. It's formally defined as the inability of the spine and the thorax to support normal respiratory function and postnatal growth. And I have on this slide several things to illustrate. The first is that thoracic insufficiency syndrome can result from a variety of disorders, including primary thoracic deformities with hypoplastic chest walls, early onset scoliosis, and neuromuscular disease. And the second is that a lot of children with early onset scoliosis do not have severe enough deformities that they develop thoracic insufficiency syndrome. So this represents probably the more severe spectrum of the children who have spine deformities. And next is that neuromuscular disease I put as a separate category, and I've done that for several reasons. First is that neuromuscular disease, which includes both weakness disorders and spasticity, for example, may or may not have respiratory impairment independent of scoliosis. And often the trajectory of decline in pulmonary functions occurs because of the underlying muscle disorder. Scoliosis then becomes kind of an aggravator of neuromuscular disease and will accelerate the decline in pulmonary function. But even if you repair the scoliosis or make the deformity less severe, the neuromuscular disease often progresses anyway, and you have progressive respiratory impairment. And I think that makes for confusion about the role of treatment of scoliosis in these children and what to expect as a result of surgical intervention. So it's a little different than those children without neuromuscular disease producing scoliosis. And I think it's important when talking about respiratory prognoses to separate those two categories. Third, the third item I'd like to illustrate is that children with TIS and early onset scoliosis often present very early, and that represents an opportunity for lung maturation and lung development, but it also represents a challenge if the disease and the deformity is progressive in nature. And so one of the things I want to emphasize as we go along is that we think that as the spine changes its configuration, as you modify the configuration with your interventions, whether they be bracing or whether they be rods or fusion, that you have to measure respiratory function in a serial manner to know how you're doing along the way in this journey of treatment for the entire childhood until they become skeletally mature. And so serial objective measures of pulmonary function are really important in managing these children. The pathophysiology of the lung as it relates to scoliosis is illustrated here. I'm not going to go into too much of this in depth, but I think there are a lot of things that go wrong. We know that as you distort the chest wall, that you reduce lung volume, and as a result of reducing lung volume, the lung itself becomes stiffer, so you get restrictive lung disease. We know there's a loss of rib mobility, and therefore chest wall movement. The chest wall becomes progressively stiffer over time. This is probably the most serious of the pathophysiologic processes, and we can talk more about that if you like. We've learned that in children who do not have underlying neuromuscular weakness, that they also have reduced respiratory muscle strength and fatigability by virtue of the distortion of the diaphragm in particular, and the loss of intercostal muscle movement as the ribs join together or oppose one another. There's asymmetric lung function. I think you can see that here a little bit on this slide by the difference in the lung size, the lung shape, and the position of the diaphragms. And then lastly, particularly in children who have thoracic lordosis, there's focal airway compression, usually of the main stem bronchi. So these are all the processes that we've learned over the years as a result of small case series where we've looked at each of these features. And most are present in most children to some extent. This is a slide depicting lung function in children from 3 centers where children were seen for the very first time without any surgical intervention. And the reason I present this is because one of the questions that comes up, and I will grant you these were spine referral centers, but that how many of your kids probably have abnormal lung functions? And 80% is kind of the lower limit of lung function. And you can see about 80% of children out of this 100 kids that showed up had abnormal lung function. And indeed about 50% of them had a vital capacity, illustrated here, of less than 50%, which would be considered severe restrictive lung disease. So you're really starting out with children who have fairly compromised respiratory function. Now keep in mind there's a big gap here. These are kids who are too young to do pulmonary functions. But the important thing about this slide is illustrated by a study by Danielson, who studied adults at 40 years of age who had had fusion for early onset scoliosis during adolescence. And they had done pulmonary functions before surgery, after surgery, and then 25 years later. And what they found was that the major determinant of lung function in adulthood was the preoperative lung function of these children. That has huge implications because it suggests for all the things we do to make the deformity less severe, it's not clear that we really impact or improve lung function over time. And so what you see may be what you have to maintain throughout the remainder of the child's period of growth. Now, it's important to know that when you ask somebody if they're having breathing problems, it's a fairly insensitive way to assess lung function. This is a study that was done using a quality of life measure dyspnea at rest compared to vital capacity, again, in about 100 kids, I think about 80 kids. And what you can see is remarkable in the sense that children do not complain of shortness of breath for the most part until they're at about 50% vital capacity. And even children who have vital capacities of 25% will often not complain of shortness of breath. And the reason is because they adapt. So they become more sedentary. They become more inactive because if they are active, they become short of breath and they try and avoid it. And so what's really important about this slide is that I think history is fairly insensitive. Exercise tolerance is useful, like do you play soccer or do you play the radio? Can you climb 2 flights of stairs? But in reality, it's not very quantitative and it's not sensitive to change. And that's another reason why we try and get objective measures of lung function in these children, so we have a better idea of their loss of respiratory reserve over time. Now, you all know this kind of portrayal here. This talks about the different devices that we use and approaches. And we know this is based on age. We know this is based on severity of the deformity and rate of progression of the deformity. And where most controversy exists is in the overlapping V circles. So do you do rods at 4? Do you wait till 6? Do you do fusion at 8, or do you wait till they're over 12? And I think often lung functions can help you to make decisions, particularly in these areas of controversy. We know there are immediate changes with growing rods, for example. You have immediate improvement in Cobb angle and reduced kyphosis. We know over time you get improvement in vertebral height and thoracic height and perhaps increase in vertebral body growth velocity. But what we don't know, we have very little data, and the magic rod discussion we just had is a great example of this. We have no data on when you put in magic rods or you expand or replace magic rods, what you do to lung function. There's simply no data. So to assume you're going to make a difference in lung function is indeed an assumption. And this is, I think, highlights that if you look at correlations of many lung functions, so if, and you look at them compared to Cobb angle, whether you use forced vital capacity, which is a test you can do in the outpatient with spirometry, whether you use maximum inspiratory pressure, which is the strength of the diaphragm and the intercostals when you breathe as hard as you can in, or whether you look at sleep-related breathing disorders as apnea-hypopnea index, you see that there's really no correlation between any of these features in Cobb angle. And so to assume that you know lung function based on a radiograph, particularly a two-dimensional radiograph, I think is simplistic and will put you in danger of understanding what you're doing to lung function as you treat the child. We know over a longer period of time that we're not winning. These are two studies, one done in Pittsburgh, one done in Seattle and San Antonio. And if you look at vital capacity as an absolute number or liters, you tend to get some increase in liters over time because of growth. You may even see a stabilization of liters, but no growth. And what we know from vital capacity, if you predict vital capacity based on arm span instead of height, is that you get a gradual reduction in vital capacity over a period of 6 years in both of these series, despite placement of growing rods, despite spine fusion. And so we're losing a little bit gradually over time, somewhere between 16 and 28%. And this is important to know because I showed you how abnormal lung functions were prior to surgery. And so this is a real challenge in terms of how do we actually improve this. The last thing I want to mention in this short time is that we've tried to look at other functional outcomes. And this is important because people say vital capacity, that's nice, it's a number, it's a test, so what? And so we've tried to look at other measures of function. And we've looked at exercise tolerance using a 6-minute walk and cardiopulmonary exercise testing, growth velocity, which is illustrated on this slide here. You can see the number of kids who have body mass indexes of less than 3%, poor sleep quality, how often do they get sick, how often do they get hospitalized, and what happens in childhood. And what I can tell you is 6-minute walk and sleep quality are not related to lung function. So this makes it even more problematic. And how do you relate these functional outcomes to what we measure in terms of breathing and what you measure in terms of structure? We do know that cardiopulmonary exercise testing is directly related to lung function, and we think weight gain and velocity is directly related to lung function. So we have much more to learn about this as we try and figure out outcomes that we want to achieve in taking care of these patients. So where do we go from here? Can we better preserve lung function measured on first encounter? I think it's really important to know what you're dealing with when you first encounter a child and how far behind the 8 ball you are in terms of what their lung function is like when they first present? And can you preserve that? More importantly, can we improve that? And right now, we don't know how to pick those patients out that might improve the most. Do lung functions improve with certain procedures? Well, there is no comparative data. There's very little data in the first place, but there's no comparative data to say traditional rods or magic rods or tethers, for example. There are lots of new techniques. It's difficult to know how those impact lung function, and certainly no comparative data at different time points and different ages in children. Is timing of surgical intervention important? I think this is a really important question because you have flexibility, you have growth potential of the lung, you have deformity potential of the spine, you have different techniques, and all of this right now is poorly described and I think begs more research. I'll give you some take-home lessons. I think we need to measure functional outcomes that result from spine and rib deformities and the surgical and non-surgical treatments that we use to try and improve the deformity and ideally improve functional outcomes. We need to measure functional outcomes serially. I think this is really important. You just don't do it once. You look at these children, their deformity progresses, they have an intervention, it looks better, you use replacement, you expand, you change your technique, you use fusion. All of this is really to prevent progression, but essentially you're also trying to improve functional outcomes, and we need to measure those at multiple time points in the child's course. And then I think we have the opportunity to improve respiratory outcomes. We're looking right now at the proportion of children who improve after spine fusion. That's very different than looking at the mean for the entire group. And for different diagnostic categories such as neuromuscular disease or syndromic disease or congenital scoliosis, there may be very different proportions of patients that improve as we intervene surgically. And so with that, I thank you for your attention. And I don't know if we have questions, Alaa, but I'm happy to answer if we do.
Thank you, Dr. Redding, for this wonderful talk. Actually, it is always a big question about the lung function in our work. But for the questions, if you don't mind, we'll go to the end and ask question. Actually, for Dr. Chung, it was exceptional because of the time in Hong Kong. So and now I'm happy to introduce Dr. Ron Hawari. Ron Hawari is a professor in Halifax. He's a well-known surgeon in early onset scoliosis. He has a lot of contributions, and he's very active in the SRS, in the Growing Spine Committee, and he'll talk about spine growth in early onset scoliosis. Ron?
Thank you, Ala. It's a pleasure to give a talk. I enjoyed it a couple of days ago, and it's a really educational week of sessions. So thank you again. My disclosures. So we'll start with a case-based kind of presentation to talk about spine growth and early onset scoliosis and how to measure spine growth, not just in 1 dimension or 2 dimensions, but in 3 dimensions, and how the different ways to assess spine growth may lead to very differing results. So this is an 8-year-old boy with spinal muscular atrophy type 2, and he's had progressive scoliosis. So in 2016, this is deformity, so a left thoracolumbar curve with pelvic obliquity right higher than the left, and a very significant global kyphosis. And at that time, we were doing 3-dimensional lung volumes on these children who were not able to comply with lung function testing. And his FEV1 and FVC were 50% predicted. And we take advantage of the 3D lung reconstruction to also look at the chest wall, and you can see some of the rib deformities that are present, very typical with SMA. We plot his 3-dimensional lung volume on a growth curve, and you can see at that time that he was around the 50th percentile, so not terrible for his age. This is a fairly blunt instrument, as you'd heard from Dr. Redding. So immediately post-operative with magnetically controlled growing rods with a hybrid fixation, we attempted to have fixation to the ribs proximally to try to prevent the parasol type deformity of the chest wall that occurs over time with SMA. And we purposely didn't try to correct too much of his kyphosis. And our premise, and you'll see on some of the x-rays, is that with lengthening of the straight portion of the MCGR, that will in fact correct his kyphosis over time. So with several lengthenings, at that time we were lengthening every 3 months. Currently we're involved in a randomized control trial and we're doing lengthenings prospectively in patients every 6 weeks. Here he is in 2017. You can see the length that's gained on both of those x-rays and some improvement in his kyphosis as well. And one more year, so here he's 2 years post-operative. So it's a good time to stop and reassess how we've been doing after 2 years of treatment. He's now just turned 11 years of age. His FEV1 and his FVC are 30% predicted. We're able to complete those now at his age. And his lung volumes hadn't really changed. Looks like they actually went down a little bit. And looking on this growth curve, he's down to about the 5th percentile for his age. Jason Howard and Abdul Jabbar Al-Hamoud did a systematic review looking at SMA and the impact of scoliosis surgery. It wasn't for early onset kids. It was really looking at fusion kids. And what they found was that there's some conflicting evidence that surgery is often associated with a decrease in pulmonary function. So even though you do surgery, the pulmonary function will still go down over time, that it doesn't reliably improve over preoperative baseline, but it may result in a decreased rate of decline. So what they determined from the literature is that with fusion operations in SMA, that PFT's pulmonary function continues to decrease, but at a less steep rate of decline than if you didn't do any surgery. They're now studying this in early onset. So we'll continue on with this child. June 2019, he had his nusinersen port inserted. And here are his x-rays. We weren't successful in preventing this parasol deformity. You can see the shape of his ribs are a lot more vertical than they used to be. So health-related quality of life is super important here. And then we're going to get into the nuts and bolts of the spine growth. SMA is one of those conditions in which the growth-friendly type intervention is shown to increase their health-related quality of life, mainly because their quality of life is so poor to begin with. And this boy had started at about 39 on his EOSQ 24 and increased to about 59 and then dropped down to about 48, but still certainly a bit of an increase over time. He's very functional in his community. He's a baseball fan. He's had a chance to be a mascot for some professional baseball teams in Canada, and he's a real advocate for SMA. Now, he's a great case example for spine growth because we've been able to study his spine growth in 3 dimensions. Typically, we've used the data from D'Amiglio, excellent data on spine growth on a coronal plane, so just 1 dimension. And you can see that measuring T1 to T12 in a newborn, it's 12 centimeters, and it increases to about 28 centimeters by adulthood. And similarly for T1 to S1. And D'Amiglio had determined that growth is bimodal, a lot of growth in the first 5 years of life, then it's quiescent from 6 to 10 years of age and then increases again. So really, really important contributions. And that's how we start looking at spine growth in that 1 dimension and use D'Amiglio's data to help correlate some of this. And I'll caution that whenever you're looking in the literature at any studies that look at spine growth, when you're looking at the 1 dimension, that should be called spine height rather than length. So here we're looking at the height of the spine. And I'd also caution you that if you're looking at the effects of a growth-friendly treatment, you need to look at the growth from immediate post-op to the most recent, this true growth phase. You shouldn't count the growth from the insertion. That's really just correction of deformity. That's not growth at all. So if you're counting this, that's the effect you'd get from doing a fusion at that time. So what we really care about is this true growth phase. So make sure you're looking at these studies and looking critically at the post-op growth, not the pre to immediate post. So now when we look on the lateral view, what we can find is that he does have, again, a little bit of improvement in his kyphosis, but over the next several years, his kyphosis improved considerably. So you can now look at the scoliosis in 2 planes. You can look at the sagittal spine length, and now I'll show you a couple of comparisons. If you're comparing we can just focus mainly on his thoracic spine height. in the one dimension. So T1 to T12 preoperatively. So the top of T1 to the bottom of T12, you draw a line from the bottom of T12. So that's the coronal spine height. That's what Demiglio's data represents. You can compare that from pre-op to post-op, and then post-op to 2019, and you can see the increase 14 to 18 to 20 centimeters. And you can also look at the same for T1 to S1. So you can say, yeah, he's grown 24 to 32 centimeters. We've done a really good job. And you can do a few calculations based on the expected growth, based on what Demiglio had demonstrated. And you can show that that 3.6 centimeters that he gained in the thoracic height ends up being about 86% of the growth that you'd expect for a child over those years. So we did reasonably well, but that's in the one dimension. We're going to come back and look at it in a couple of different ways. So at that point in time, we were examining spine growth really just in one dimension. And Charlie Johnston and Laurie Carroll had published this 18 centimeter rule in which they found that if the pulmonary function, if the thoracic height was greater than 18 centimeters at maturity, that pulmonary function was better in children. And what we found looking at the results of some PSSG patients, this is traditional surgery, not MCGR, but mainly Vector and growing rod surgery, that percentage of patients that reached 18 centimeters with 5-year follow-up, it differed on etiology. So at the low end was congenital, only about half of them reached 18 centimeters, whereas the syndromics were closer to 86%. So if we look at the data by Johnston and Carroll, their thoracic height, 18 to 22, you want to get at least 18, hopefully over 22. You see how that correlates with percent FVC. They're the first two people to admit that it's not perfect science, but it's a best evidence that was available at the time. So if we look at our child in this case example, that when you look at his T1 to T12 at the age of 11, it's 20 centimeters of thoracic height and 32% FVC. So he's kind of right about here. So he's not doing great. So whenever we see somebody with kyphosis, patients like this young boy stimulated us to start thinking about two-dimensional spine growth. So that's the out-of-plane growth. So if you're just looking on an AP X-ray, you're seeing this straight line. You're ignoring the arc of the spine where the spine really is on the sagittal plane. And we were able to devise a way to evaluate the length of this arc of the spine, what's called the sagittal spine length, and we validated this so that if there is kyphosis and the kyphosis changes, you're still able to capture that length of the spine. You're not missing that if you're just looking at the coronal plane. And you simply digitize on a lateral X-ray the superior end plate at each of the different vertebrae, and you can calculate the length of this arc. And what we found is that comparing the difference between the standard coronal plane spine height versus the sagittal spine length, it didn't really make much of a difference for normal kyphosis. But once you get over about 40 degrees of kyphosis, certainly over 55 degrees of kyphosis, it makes more than 4 centimeters of difference. So if you're just looking on the one plane, you're going to miss this length. So a lot of posterior distraction-based systems are kyphogenic, so they cause kyphosis over time. So you have to look at it from the sagittal plane so you're not missing out on that potential growth. So coming back to our patient, we also have our T1 to T12 here, just on the coronal, and then we have our sagittal spine length T1 to T12 here, and you see that difference, 14 centimeters in the one plane, 20 centimeters if you're looking at the sagittal spine length just in the thoracic. And by doing that now, you can see that the difference in the spine height is much less 3 years later. We calculated this difference for T1 to T12 on the coronal plane PA to 3 years later being 5 centimeters. Sounds like a huge improvement, but what we found looking on the sagittal, it was only a 0.8 centimeter difference, so not quite as good if you're respecting both views. And then the final thing I'll touch on is you can still do the same thing, but in 3 dimensions. So you're doing your sagittal spine length on the lateral. You can also do your coronal spine length, looking at the arc of curvature of the spine on the AP, and create a three-dimensional true spine length. And that's been validated as well. It's been reliable and repeatable. And now if you look at this same patient and you look at things in 3 dimensions, his T1 to T12, there's really not much difference from pre-op to 3 years later, maybe 1 centimeter of difference. So if we're looking at it in 1 dimension, we think we've hit a home run and we're doing really well with the increase in the spine height. But if you look at the true spine length in 3 dimensions, it's only 1 centimeter of difference. And I think it's really important to consider all 3 of those dimensions to be really evaluating the growth and the effects of any of the treatments that we're doing. Because I think we've been overcalling things in the past, looking at it traditionally. Again, in this patient, thoracic spine, 5 centimeters, sagittal, it's about 1 centimeter, and really no change in 3 dimensions for a thoracic. So we're in a process of compiling data for normative data for patients in 3 dimensions, and we're collaborating with Stefan Perrant in particular to create these growth percentiles to tell us what the true spine length should be in 3 dimensions in children at different age groups. And if you look at our patient here, when he's at the age of 11, you can see he's actually not doing too badly here. He's above the 90th percentile. So I think this is really where the money is when you're looking at the length of the spine rather than just a coronal plane AP. And potentially that's going to correlate with pulmonary function and correlate with health rate of quality of life. So in conclusion, spine growth is very complex. Think in 3 dimensions. The height of the spine may not always correlate with pulmonary function. Think about the disease, as Dr. Redding had said, neuromuscular may be a little bit different, such as in this case with spinal muscular atrophy. So thank you very much.
Thank you, Ron, for your excellent presentation. And now I will proceed for the next speaker, and gives me great pleasure to introduce Professor Ala Azmi from Ramallah, West Bank, Palestine. I always admire Ala's work because he's working in very difficult circumstances, limited resources, occupied land, and he's producing his innovations. So today Ala will gonna talk on the active apex correction with posterior tethering technique. Ala, can you proceed, please?
Thank you, Yusri, and it's an honor for me to be contributing to this program, and I'll talk about the APC technique that we invented, and it's called active apex correction. And this is my email and my WhatsApp in case anybody wants to ask further questions in the near future. I'll talk 1 minute about early onset scoliosis. Early onset, according to the SRS, is whatever the etiology is the spine deformity below 10 years of age. And there's a myth about that early onset scoliosis is not a big population, but here we can see that with congenital scoliosis, infantile idiopathic and juvenile idiopathic, it's more than 10% of the adolescent idiopathic cases. It's nearly 20% of the adolescent idiopathic. So we have a lot of problems, and it's life-threatening also. So what is the main ideal management of early onset scoliosis? To have a corrected mobile spine with normal trunk and growth with minimum complications. This is the main aim of it. And dealing issues within the last 2 decades is the importance, as Dr. Redding and Ron have said previously, about the importance of looking at the surgery. So the importance of casting raised up again and avoid fusion with evolution of non-fusion options. And surgical technique, there are many surgical techniques and prove some of efficiency in dealing with early onset scoliosis. But until now, we don't have a real superiority, as was said in the previous presentations, and still the complications are high. So we must think about not the spine, we must think about, when we plan for surgery, age, curve severity, curve type, growth remaining, general health of the child to tolerate multiple surgeries, a relationship, the factors must be considered in relationship to the benefit of continued growth of the spine. This is one of the major issues that we must in advance think of the child with early onset. So when we talk about the technique, it's just a technique, but we must consider other issues after that. So the tethering is like teeth braces in children, in which teeth will mold in straighter position with growth. And this is what we hypothetically say about the spine. Now, what is the uniqueness of the active apex correction technique? Is that we do tethering through posterior approach, and this is a kind of a modification of the Sheila technique, that we include two systems. As we know, there is a distraction-based system, guided growth system, and the compression-based system. So we joined the guided growth and the compression-based. How did we do that? As we see in this, on the left side, this is the Sheila technique. That it's the main concept of Sheila technique is controlling the apex of the curve, but it's done by fusion. At least you have 3 levels, and you put screws at 3 levels. And we know what's the meaning of putting screws on the concave side in young children. It's really risky, and the sliding of the rods are proximally or distally or both. What we have done is that instead of controlling the apex through fusion, we control the apex through modulation and tethering. So, for example, if this is if we have the most wedged vertebra in between, we have a screw above, screw below on the convex side, and we compress them, so it will be a tethering effect. And we think hypothetically that the maximum wedged vertebra will slide, will modulate. And what we have done, we can realize from the 3D CT scan that we did for the patients preoperatively and in the last follow-up, that the height of the spine of the most wedged vertebra was 50% in the ratio between the concave and the convex side, but it modulates with time and it will be 70% instead. Some surgical technique, details of the surgical, this is a 7-year-old child. She's having, as we can see, it's nearly 66 degrees of scoliosis. And we can see with the green line here, the most wedged vertebra. And we put a screw above, screw below on the blue arrows. And we can, so this is the tethering, but we have proximal and distal anchors to go through. And either I would do 3 separate incisions to decrease the bleeding. Even sometimes I go, I feel that it's very hard to go with the rods in between, so I open in between them, but in the beginning, at least to control the bleeding. And this is the tethering. We can see here the screws above and below, and I didn't touch the most wedged vertebra in between. This is the apex of the curve. And in the green, on the red line, we see the most wedged vertebra, and we can see here the proximal and the distal screws. And of course, on the right side, we can see the anchors proximally. And so these are the tethering screws on the convex side. So it's less risky than going with the screws on the convex and the concave side. And here we put the tethering rod. Actually, now I put the tethering rod as a separate rod. And one of the learning curves that I had through time is that don't put the 4.5 rod, even if the child is very young. Always try to put the 5.5 rod if it's titanium, or at least 4.75 cobalt chrome, because it's biomechanically like the 5.5 rod. And here we press in between the screws that are controlling the apex, as we can see here. And usually in the thoracic spine, I have about 7 millimeters of compression, but you must be aware that you don't dislodge them. And in the lumbar area, I usually have at least double, 1.4 or 1.5 centimeters. Then we go here, we can see here are the tethering screws, and here's the tethering rod. And we connect the tethering rod, as you can see, proximally and distally with dominoes. And this is the concave side. And as you can see on the concave side, beside putting screws above and below as proximal and distal, I don't touch the spine here. So it's really an unfusion technique. and we connect the proximal and distal rods with domino, and we lock one part, and we get the rod to be sliding on the other part. And I'll show you how's that. This is, when we go back to the previous one, this is the concave side. So we distract to the maximum as much as we can here to get as much correction as we can on the concave side, the cup, but how to avoid migrating the rod upwards again? We usually lock one side, as we can see here, but this side is open, so as the rod will slide, but we lock it from the proximal part, so it will not migrate upwards and it will slide only downwards. How can you do that? Sometimes I do it with one piece, one head of the cross links. I put it here and lock it, and sometimes you put a screw. You break the screw and you put the head of the screw so as to prevent it from going upwards again, and it will only distally slide through the unlocked domino here. And here you preserve at least 4 centimeters of the rod to slide. So hypothetically, it will have 4 years to slide without getting back to distraction as in the traditional growing rod. Here is the same child, as we can see how the correction became afterwards. And these are the sliding rods on the yellow lines, and within the blue line are the tethering rods, and here is the lateral, and you can see the difference even in the shoulders and everything. This is another case that I had a child of 5 years of age who had severe scoliosis, and I did an infusion with just 2 wounds, and you can see this is the child who had severe he's decompensated, he was having severe scoliosis. I just put 1 incision above, 1 incision below, and we can see here that it was about 62 degrees. He had actually congenital scoliosis with a unilateral bony bar here, and you can see there's a proximal curve of 41 degrees even, and these are the 2 tethering screws actually. And because it's so narrow to the distal anchor, so I just put one rod here as a tethering rod, and it also included the L1, so it wouldn't affect actually the lung and the thorax. And here we can see it became about 15 degrees. And here is the sliding rod, and you can see on the concave side the sliding rod and the head that will prevent the proximal migration of the rod. Also, another trick with less invasive technique for an 85 degrees cup angle, and this is a case that you can see the difference of the child pre and post operatively. But you can see here, these are the tethering screws. These are the dominoes that connect the convex side through proximally and distally, and always the tethering rod is locked. The other ones are unlocked for migration. And you can see the concave side that we connect the proximal and the distal without touching any part of the concave side. And you can see it was 87 degrees and it became less than 50 degrees afterwards. There is another issue that when I use the 5.5 rod, sometimes I use percutaneous screws as in this girl. So you can see just a small screw, small opening for percutaneous screws as a tethering technique, and you can see the difference also pre and post operatively. Another issue, if you have severe kyphosis, and like this case with severe scoliosis and severe kyphosis, I don't advise using the dominoes in the beginning. You just put the rods, and here I put hooks instead because of the severe kyphosis, so as not to dislodge when you put it as screws in this child who's usually osteoporotic. And I put just 1 rod, and then afterwards on the right side, after 1 year, you change it and you put the dominoes. But if you have severe kyphosis or very severe scoliosis, like this is 90 degrees and this is 90 degrees, don't put the dominoes in the beginning. Try to have maximum correction and then put the dominoes after 1 year. And you can see the difference also of the kyphosis. after putting on the left, after putting the rod, and then on the right, after putting the dominoes, which you preserve your correction. And this is a published study that we have done about this technique. And in comparison to the traditional growing rods that we have done also with the APC, and we can see there is no there is statistical difference, though in the APC, we don't go every 6 months for distraction. Benefits of the APC: 0 osteotomies, no screws on the concave side, 2 screws instead of 6, hybrid technique, you can use it, cheap and can be done with regular spine implants. You don't need to go through a specific company, and all what you need is just regular implants. Avoid recurrent surgeries through rod sliding. And this is a study that we have done in the University of Toledo, and actually it will be presented in the NAS in the meeting in Boston about this technique. And we had wonderful results about the spinal length, the spinal growth, and the modulation of the vertebra in between. In conclusion, treatment of EOS is challenging because it's heterogeneous population. No consensus is established until now. The cornerstone in treating early onset scoliosis is facilitation of optimal condition for lung development, spinal growth, and thoracic growth. Spinal fusion should be postponed as much as possible. There is more awareness about the holistic approach with consideration of the impact on multiple treatment intervention on the family and on the child. Operative complications might be reduced by delaying the age of initial implants, using dual rods, submuscular implantation, and limiting the number of lengthening procedure, thus reducing the number of unplanned surgeries. And finally, stick to the principles to refer the patient to the appropriate specialist. Do the surgery with the scars that you have. Do what is appropriate related to your experience, and don't shift to the maximum issue. Don't hesitate to ask for help. It's a teamwork process. And these are references of the publishings that I have done about the tradition, in case somebody would like to read about them in global spine journals, in peer-reviewed journals. And this is a book that we have done about, I'm the main author, about early onset scoliosis guidelines for management in limited resources region, in case somebody would like to read about how to put this technique in low middle income countries with limited resources. And here we are having blended learning courses in Africa and in Latin America about scoliosis and early onset scoliosis. Thank you very much.
Thank you very much, Ala, for your good work. And now we'll proceed for the next speaker. And it gives me great honor and pleasure to introduce Professor Hisham Al-Saghir, one of the pillars of spine surgery in Alexandria and also in Germany. Hisham is going to give his talk on how frequent is it necessary to do the finer fusion after growing rod treatment in EOS. Hisham, can you proceed, please?
Thank you very much. And it is a very wonderful Congress. I congratulate you for continuation of this annual activity. Well, after the talk of Dr. Azmi, my talk will not somewhat different, but he gave the most of the principles in the challenging EOS treatment. Well, beginning. Well, my experience with the growing rod technique is somewhat complex because every one of us has his experience, and usually we learn from what is called complications. And whatever the treatment modality, we will not be able to allow the normal growth of the spine in the EOS patients. Anyhow, growing growth treatment is much better than early correction and fusion. And sometimes we get the impression that whatever you are going to do, the spine is getting gradually fused during the lengthening surgery. And not uncommon in progressive curves that we have the feeling that we are fighting to maintain the achieved correction and to prevent correction of the curve. Well, this is a case, 5 years old child was treated by one of our colleagues, and this was for 8 years. And he used that just for the proximal foundation, 1 screw, for the distal foundation, 2 screws. And later, backing out of the upper screw, reinsertion, CT, revision at a higher level, failure, backing out again, 2 screws, backing out again, and severe deformity. Well, this is after revision using domino, and here addressing the curve, that is a double curve, and we must make proximal and distal foundation for each curve. And this is after lengthening, but after 3 years, it wasn't possible to achieve any more lengthening. Another case, 6 years old girl, 2 screws with domino, failure, revision with using domino with dominoes and using foundation, proximal and distal foundation for each curve. And this is after, at the end of the follow-up. This patient developed empyema, and we see here the scar of the thoracotomy. Our experience in Alexandria in the ortho unit that we must deal with the curves like in adolescent major curve. We must do proximal distal foundation and apical instrumentation. For mobile curves, posterior fixation is sufficient. For rigid and severe curves, anterior release and with result fixation is needed. For double curves, proximal and distal foundation for both curves, and the lengthening interval is about 1 year, but with increasing screw density during the lengthening journey. This is an example. And here the apical control is achieved through single screw, 3 incisions. Well, what we see as failure of foundations, rod breakage, difficulty to keep the sagittal curve, progression of transverse plane deformity, stiffening, and the need for instrumentation is nothing but an expression of progression and insufficient fixation and the lack of fusion. And actually, this is very common. What we see, what we call complications in normal spine surgery is very common, nearly 100%. And if the definition of complication means unanticipated occurrence of difficulties, then we must consider these events as not as complications, but as events, and we must tell the parents of these patients about this scenario, that screw backing out, rod breakage are commonly expected. Example of severe thoracic curve, and here anterior tethering and posterior instrumentation, repeated lengthening every 1 year, and after 5 years follow up. And actually the principle of increasing the screw density during growth helped us to reduce the progression of the curve, but was at the expense of premature fusion. Well, from 19 cases, only 8 cases needed re-instrumentation and fusion because of progression of the curve or major metal failure needing re-instrumentation and fusion. Thank you very much.
Thank you very much, Hisham. Very clear presentation. And I'm sorry I missed the turn of Professor Mohammed Wafa. Professor Mohammed Wafa is one of the pioneers of spine surgery in Egypt, and he's the professor of orthopedic and spine surgery in Ain Shams University. And Mohammed is going to deliver his talk on meningeal effect. Can you proceed, please?
Hello, everybody. It was a good chance actually to speak after Hisham and Ala. So I have a question. When do you really go for fusion, and when do you really just, I mean, after lengthening, after progressive lengthening, when do you really go for fusion? Do you hear me?
Yes, yes. This is a very good question. Actually, after 3-5 lengthening during surgery, we find that it is not possible to achieve more lengthening. And the patient had the correction is okay, the spine is balanced, and the hard way from density here is not like in adolescent scoliosis, but there is no movement. Actually, I don't do fusion. I'll tell the parents, let him sew. If breakage occurs for the rods, we can interfere because he will lose nothing. He will lose nothing if we wait for a couple of years, because usually during revision we use 5 millimeter screws. The problem is the rods. It's a 4 millimeter rod. And from the old experience with Harms, that 4 millimeter rods, Harms had operated scoliosis with 4 millimeter rods for years. And the difference is not so much between 4 millimeter rod and 5 millimeter rod. This is why I say I tell the patient, tell the parents, leave him so for a couple of years. Actually, I don't have experience for 20 years to say that this is functioning, but the majority, about 60%, didn't need re-instrumentation.
Okay.
Did you hear?
Yes. I think I have a little problem here.
دكتور محمد، حضرتك كنت عملت شير سكرين بعد كده وقفتها، ممكن حضرتك تعمل شير سكرين تاني؟
انا مش طالعه لي تاني كده. started with Zoom.
طب ويندوز زوم قدام حضرتك ولا يعني ولا مش ظاهره قدامك؟ يعني حضرتك شايف صوره دكتور هشام ودكتور بيناي ولا مش شايفها؟
انا شايف
طب ما فيش شير سكرين او في، لا حضرتك لو الشاشه صغيره بيبقى في سهم فوق على اليمين، حضرتك دوس عليه عشان تكبر الشاشه كلها ويظهر زرار الشير سكرين.
سهم صغير.
حضرتك في زرار شير سكرين اخضر تحت يا دكتور ولا مش ظاهر؟
لا مش ظاهر.
طيب حضرتك دبل كليك على الزوم كده يا دكتور عشان تكبر الويندو ويظهر الزرار مع حضرتك.
دبل كليك على الزوم اللي تحت خالص ده.
حضرتك شايف الصوره بتاعت السبيكر صح يا دكتور؟ فول سكرين ولا
كنت
شايفها؟ كنت شايفها. طب حضرتك افتح الزوم تاني من تحت، من البار من تحت.
تعالي يلا ورينا كده. هو في عندي مشكله في الساين ان كل شويه.
لا يا دكتور حضرتك كنت معانا وكنت عملت شير سكرين، ما كنتش تعمل ساين ان تاني، كنت محتاج تفتح الباوربوينت بس.
اوكي. كنسل. ايوه كله كده باين. طب بالنسبه لعلاء امتى
انا الحقيقه ما حبيتش اقول عشان انت مشغول. Well, I usually hypothetically speaking I don't do now with the APC I don't do traction every 6 months, and after 4 years if the patient is about 11 or 12 years and he or she is compensated, I wouldn't do anything and I'll keep just whatever it is, like Hisham idea also. But if the patient is decompensated, I'll go and correct and do final fusion and replace the implants with 5.5 rods or the bigger.
Right. Because, and this is in idiopathic, in idiopathic early onset scoliosis. But what would you do with the neuromuscular? Do you just keep lengthening and then leave the implants inside, or would you?
If the patient is compensated, do anything. If the patient is decompensated, this is the core of the issue. If the patient is decompensated or having progression in the decompensation, then I'll go and remove it. But I wouldn't go a procedure that might not be absolutely needed for the patient.
Right. So you depend on spontaneous fusion, that this will happen anyway.
Exactly. Yes, you're right.
Okay. I'm very happy to join your meeting today also. And my turn is to speak about kyphectomy with myelomeningocele, which is one of the devastating problems actually to the family, to the patient, and to the local community of this patient. And it results from failure of the neural tube. And then this results in herniation of the meninges and spinal cord through the vertebral defect. And this could be detected by the 4th week of gestation. And the etiology is not very clear. It happens sometimes as a sporadic case in a family and related to trisomy 18, more with maternal use or abuse of alcohol, caffeine, and maternal diabetes mellitus also. And it's connected to the low maternal folic acid, zinc, vitamin C, B12, with maternal smoking, obesity, and stress, or fevers, or exposure to external heat in the first trimester. And it's found with amniotic bands. It's unclear anyway, and the epidemiology is strange. It's more in females. Why? We don't know. And it's about 0.2 to 0.4 in 1,000 in the United States, more in Latinos, but it's much less in Finland and much more in North Ireland. However, it's higher with high maternal age. And why with low socioeconomic status? It's unclear. And it could be recurrent. I mean, it happens in the second child in a family if the first had the problem in 2 to 3%. Could be detected? Yes, it can be detected early in the intrauterine life with ultrasonography or with high level of alpha fetoproteins. And in this point, we have to do counseling with the family to explain the problems they are going to face if this pregnancy is continued. And in our community, I mean, there's no question. 99% would say yes, continue with this pregnancy and get us this child, and then we'll see how it goes. Maybe in other communities they would prefer termination of pregnancy. And if they decided to continue with the pregnancy, then fetal surgery now is an option. And on randomized controlled trials, the efficacy of prenatal surgery versus postnatal repair, they found that there's less need for CSF shunts postnatal, and improved mental development and improved motor function when they restarted at 30 months of age. And this, of course, 3 points are in favor of prenatal surgery or prenatal closure of the defect. Mortality rates is 1% per year from 5 to 30 years. The higher the lesion level, the greater the mortality rate. And they are also always exposed to psychological problems like depression, anxiety, and risk-taking behavior. Why do they get deformity? They get deformity maybe because of three reasons: because of the trunk muscle weakness, neurogenic factors like tethering or C-rings or Chiari malformations, and also because of associated congenital malformations. 1/5 of them, they have hemivertebrae or unsegmented bars. And it's well known that when the thoracic, when there is lacking of the function below the thoracic level, they develop scoliosis in 50% of these patients. Now you're getting to the treatment. Most of the treatment here is surgical. The conservative treatment in these patients with braces and well-adapted chairs is maybe more helpful than in other types of neuromuscular deformities, and could be tried in the early ages, but it does not prevent the interference later on if there is a progressive deformity. So if you plan to do surgery, first inform the pediatrician. Give him a few months beforehand to get your patient ready for the surgery with adequate nutrition, and maybe a gastrostomy tube also could be helpful. Improve hemoglobin percent. Lymphocytes should be more than 1,500 per cubic millimeter, and the albumin level should be more than 3.5 grams per deciliter, so you may get better wound closure or wound healing, I mean. And there are some considerations for surgery. Get the help of a neurologist with you to do some evaluation of the neurological function, and he can evaluate the CSF shunt function and length if you need to get more longer shunts. Rule out tethering in patients if they have some distal neurological function, if they have movement in the legs or some power in the lower limbs. So you have to rule out tethering, otherwise you may end up with a loss of motor function. Analyze skin coverage. You may need the help of a plastic surgeon. They have to look and see the previous scars of the trials of closure of the defect, and then they may need skin expanders, and they may need to plan some muscle flaps after you correct the deformity. And check for hip contractions. If there is a hip flexion deformity more than 90 degrees or around 90 degrees, it's better to get osteotomies of the femur or even resection of the femoral heads and necks before trying to correct the deformity. Otherwise, you will never benefit from this, because you correct the deformity and the legs will be touching the chest. The gold standard in these techniques is posterior instrumentation fusion, plus limited anterior fusion with or without fixation anteriorly. Why do you need anterior fusion sometimes? Because there is frequent rod displacement in posterior-only surgery. Many times because of the soft bones, the instrumentation get loose. And the remnants of the posterior elements provides a small surface area for fusion and high infection rate and pseudarthrosis. We'll see the complication rate later on. So anterior fusion protects against non-union if the posterior instrumentation fails or if the posterior, there is a posterior infection. So we use to do anterior fusion around osteotomy in kyphosis, multi-level discectomies, and grafting in scoliosis. In kyphosis, where the osteotomy is done, then fill the gap anteriorly or fill around the bones anteriorly. But if scoliosis, we do easily to do multi-level discectomies and grafting. But cases with small curves or there is little risk of differential growth or crankshaft phenomena, use posterior fusion is usually enough. And there's another point in these patients, they get early skeletal maturity. So the discarding of the braces or the crankshaft phenomena are much less than in idiopathic deformities. Another point in the consideration for surgery, would you go to the sacrum or not? This is a very important point. You may stop at L4 or L5, and this would allow for some distal mobility. And then we use this if the patient is a walker. And these also have the value of decreasing the pressure source over the ischium because there's still some mobility at L4, 5, S1 levels. To fuse to the sacrum, if you have a pelvic obliquity more than 15 degrees, so this gives better control of the pelvis, and then the patient will be able to sit without the use of hands, and no need for braces or custom-made chairs because he can sit more or less freely. Technical consideration. Infection here is much higher than other surgeries. So prophylactic antibiotics, putting in mind most of them get gram-negative organisms. Neuromonitoring, if the patient still have the lower limb function. So we do neuromonitoring during operation and put the electrodes in the quadriceps. Start dissection from the normal area to know the depth, where is the cord. So to avoid the CSF leak, and confine dissection to the bone. It's if it is, in an area where there's no previous scars, then it's easy. But the problem is that they always have many previous scars. So it's really, you need to be to take severe caution not to injure the dura. And you need multiple fixation points as much as you can. And if you put pedicle screws, you can easily feel the medial wall. Here the pedicles are more convergent than usual. The pedicle is narrow, so you may need smaller screws, but the sharp angles, the convergence is more than the usual. أنا عايز أقول حاجة بس أنا مستغرب إزاي لسه في نور عند هشام الصغير في اسكندرية وإحنا عندنا هنا الضلمة بقت كتير. الشمس مش هتغرب عندكم النهارده الظاهر. Going back, I'm sorry, going back to the technical consideration, the vertebral bodies here also are shallow, so the screws are small and short. Pelvic fixation is commonly needed. So the sacrum, putting in mind that the sacrum is small and porotic, you have to be careful. So when you put rods in the sacrum or iliac screws, you better use cross-link just immediately above the pelvis at the level of L5 or L4 so prevent pulling out of the iliac screws or rods from the ilium. You may need bone cement augmentation. Usually we start surgery between 5 and 8. Don't get it too late, and it's very difficult to start very early. And it's amazing that most of these patients have latex hypersensitivity. They said that. I've never seen this. So you have to be careful in choosing your gloves. So what to do in these cases if there is a sharp or there's a, as you can see here, marked angular deformity. So if it's a small, smooth curve, then multiple deconstellation osteotomies will be enough. But like sharp gibbous like this, you have to come from the beginning of the deformity to osteotomes and cut this U-shaped piece of bone out. The cord could be mobilized at the apex. We'll see this in steps. Or maybe transected. I've never transected the cord. I cannot just do it. I don't know why. But the apical vertebrae and enough adjacent levels are resected. So when you get the correction, then the soft tissue envelope would be enough for the length of the spine. Fixation to the pelvis, fecular technique. Here, 2 rods with double 90 degrees bend, put in the first sacral foramen, and then you apply posterior directed force to the sacrum as leverage against the kyphosis until the upper part of the rods come close to the dorsal spine, and then use sublaminar wires. You may add pedicle screws in the lumbar vertebrae also. Stop usually at T4, and fusion of the anterior, fusion anteriorly here is very helpful. How to fix to the pelvis? You may need the fecular technique, Galveston, McCarthy double bent rod, 90 degrees over the ala of the sacrum, or Costwick transsacral bar, which we used to do in idiopathic scoliosis with Harrington rods in the past. Screws in S1, better with parallel in L5. If you put in S1, make some more strength of your fixation of your construct by putting screws at L5. May use convergent and divergent screws in S1 and S2, Jackson intrasacral rod, or iliac screws, or iliosacral screws. This is the Galveston technique, and these are iliac screws. What I mean by the cross-link is here. It's very good to put cross-link here at L4-5 area, so it prevents the pull out of the iliac screws. And this is the iliosacral screws, and this is the sacral bar or transsacral bar, and these are the Jackson intrasacral rods. Bone graft is very important because it's this would help to prevent the loss of correction later on. So, but adequate graft is difficult to obtain because it's long fusion. You need big graft, relatively hypoplastic ilium, which are planned to put iliac screws in, so you don't have really the luxury of taking big iliac grafts. And the need should shorten operative time and blood loss. So allograft here could be the solution. Complications, infection is too high, 8 to 19%, maybe higher even. Shunt malfunction, if it become short after correction of the deformity, you need to change the shunt or get a longer one. CSF leaking 5%, pseudoarthrosis 15%, loss of correction and loss of fixation. Even with solid fusion, sometimes they get some loss of correction. And the death rate postoperatively 1 to 2%. Look at these cases. Look at this. Severe deformity, skin problems, pressure sore, old scars. The same here, old scar, although it's not a severe deformity, but the scars are very bad. and you have to plan what you are going to do with the skin problem. As I said, we do a posterior kyphectomy and fixation. We use this Fackler technique several times. It's very good and it's safe because when you put these screws in S1 foramen, it's an anatomical clear space anterior to the sacrum. Don't worry about the vessels. Vessels here are divergent on both sides. As you can see here, you can see that this is the cord. When this is a dissector underneath it, you may ligate and divide the roots. And then this is the deformity, 2 osteotomes at the base of the deformity. And then you end up with removal of this big chunk U-shaped area of the spine. And then you put the rods in and correct the deformity. As you see here. This needs Boston brace, of course, postoperatively with good grafting anteriorly here to make sure that this would heal. I'll show you a bad case and a good case. Female, 6.5 years, Arnold Chiari, malformation meningeal. The repair was done at the age of 1 year. She developed kyphosis. So what we did actually is resection of L1, 2, 3 levels, fixation from D6 to the sacrum with Fackler technique, and reconstruction by morcellized bone graft. What happened that there was a dural tear, and we did a repair, but actually it continued to get CSF leak. So we put a CSF drain, Boston brace. But what happened, you can see here, is that this is the deformity, severe deformity in the lumbar spine, as you can see. So we put these rods, but it was not very good. It was not very well done, actually, to start with. But what happened is that they cut through the sacrum and came out. So we revised this by screws in L4 and L5 and 2 iliac screws. And this was well corrected, new grafting here, and then with follow-up, this patient went well at the end. The other case, you can see this is the CT scan 1 year post-operatively. And this is another case, male, 12 years, Arnold Chiari also, meningomyelocele, repair almost at 1 year also, myelokyphosis. Resection here was a bit higher, D11, D12, fixation from D5 to the ilium or to the pelvis with iliac screws, and reconstruction by mesh cage here to guard against recurrence of the deformity. Look at this. So it's a big deformity. You can see here, skin problem. So this is post-operatively. If we use many points of fixation, that's much better. It gives you a good chance to maintain your correction. And you can see the deformity here, and this is immediate post-operative picture, and this is 1 year post-operative. And this is a clinical photograph of the preoperative deformity, and this is his back after correction. Thank you very much.
Thank you very much, Professor, for this very difficult subject and your technique and in which correction of the deformity was done without considering the skin, whether with or expanders before the surgery, and catastrophic removal with the recurrence of the deformity. So thank you for highlighting this. And I think we have to stop like for 5 minutes. I'd like to ask Hisham Al-Saghir, one of the attendees, Dr. Mahmoud, is asking you, you're doing your lengthening every year, or is it less than that? هشام الشمس غربت عندك ولا ايه؟
unmute yourself يا دكتور هشام.
Dr. Hisham, you are muted. Can you unmute yourself, please?
الشمس راحت والصوت راح كمان.
مرتبطين.
دكتور
Dr.
هشام
Hisham, you're still muted.
من الايقونه بتاعت الميكروفون اللي على الشمال في الويندو. دكتور هشام دكتور هشام you still muted.
تحت.
طب دكتور يسري may I ask Dr. Gregory Redding a question?
Can we hear from Ron?
Ron.
Hello.
Hi, Ron. The interval of lengthening, is it every 3, 6, 1 year? What do you think? It depends on the age of the patient.
Yeah, it's a good question. The MCGR randomized control trial, the premise is comparing the two different lengthening intervals, and I think that truly is one of the unanswered questions for us. We had a bunch of people in a room trying to come up with the study design, and it came down to a 6-week interval versus a 4 to 6 month interval. I've always been between 6 weeks and 3 months, and I truly believe that the quicker lengthening interval probably works better. I don't think that's been proven, but I think that might minimize the effects of autofusion. You can get short incremental gains in length over a short amounts of time, and just keep up the growth a little bit closer to physiologic growth, similar to what you do for lengthening of lower extremities, where you're turning the external fixator, 4 times a day. We can't do that in the spine, but I think the more often you do it, probably the better off it is. But honestly, we don't know that answer for sure. That's my bias, though.
So what do you think that the magic rod has worked very well in lengthening of the lower limbs or upper limbs than in the spine?
Yeah, I think that the spine is just so complex. It's extremity surgery is challenging in its own right, but generally it's you don't have to worry about joints. You're worrying about an osteotomy or a couple osteotomies. Here we're spanning multiple joints, multiple segments, and I think that just increases the complexity of areas where there's supposed to be movement, and we're limiting the movement and affecting the growth by spanning with rods. I really think that's the biggest difference between the spine and extremities.
And in your experience, the low returns, when does it happen? 3rd, 4th, 5th?
Yeah, it's debatable, if that even exists for rib-based surgery. We had been involved in a study with the pediatric spine study group about 5 years ago, looking at the growth of the spine for rib-based constructs, and there really wasn't any law of diminishing returns right up to the 15th lengthening for 5 years. I think with spine-based, I think there is a little bit of autofusion that happens. The study that was done is an award-winning study looking at spine-based growing rods for the law of diminishing returns. My only qualm with that study is that they never looked at the sagittal plane at all. They didn't report on the kyphosis, and if there was a kyphogenic effect of the posterior spine-based treatments, the way the spine height was measured, it wouldn't be captured. So I think they were overcalling the law of diminishing return. I think it's there, but I don't think it's as bad as people report. And we've looked again up to 5 years, 15 lengthenings, haven't seen it for rib-based, and a very modest effect for spine-based.
Thank you. Do you have other questions for other speakers? Mohammed?
Yes, I'd like to ask Dr. Gregory Redding, thank you so much for your presentation. As a surgeon, we know that forced vital capacity and forced expiratory volume 1, when it is less than 40, we are less hesitant, and we are less encouraged to do surgeries for the patient, because the respiratory function decrease after the surgery much more with anterior than posterior, and even after 1 year it will not return back to the baseline. So we put the 40% as a cut value for that. Do you agree with this cut value or not?
It's a good question. I don't think people have a great answer, but I think between 40 and 50%, you get increased post-op complications, number one, for early onset disease and for adolescent. And I think the other discussion that I think you brought up, which is really important, and I don't think we have it enough, is that we actually counsel patients that with fusion, even after rod therapy, that there's a reasonable chance they're going to lose lung function for a period of time, whether that's 3 months related to post-op pain or whether that's longer based on the AIS experience, that you may lose lung function easily for a year. And we actually become much more aggressive with non-invasive positive pressure ventilation at night. Knowing we're going to lose lung function in kids who are marginal in the first place, we don't refrain from trying to correct them, but we kind of anticipate that they're going to need additional respiratory help during that time. And we've used a lot of BiPAP and CPAP. We haven't resorted to tracheostomies or ventilation, but there are a lot of children we have with scoliosis following surgical intervention, and even before it, where we're using non-invasive positive pressure ventilation at night. And that tends to shorten hospital stay if they use it. And it also tends to keep them very stable, even when they have a severe deformity and significant loss of lung function following fusion. So we're not afraid of that. We just augment our supportive care.
Okay, if we have a patient with SMA and he is ventilated, shall we operate upon him or not?
I think that's a much more complicated issue. And the reason is because the data on slowing decline after SMA is a little weak. In SMA in particular, the slow of decline is less convincing in a big study that was done last year. So I think you're really balancing the risk of progression and loss of lung function with the slowing of lung function due to neuromuscular disease. I still believe it's useful because I think progression of the deformity will aggravate the underlying neuromuscular condition, but I don't think you hit a home run. I think you're there to kind of stabilize things, knowing they're going to get worse anyway. We don't refrain from that because of the severity of the illness.
Okay, thank you so much. Professor Wafa.
Can I ask? All right, go on.
What kind of rods do you use in kyphectomies? Cobalt chrome?
5.5 millimeter titanium rods.
Titanium rods. Okay, so you want to comment or ask something? Please go ahead.
Yes, I want to ask Dr. Redding also a question. For years, I'm treating scoliosis. I never imagined why or believed why the respiratory function would not improve, say, after 2-3 years from correction of idiopathic scoliosis. It should improve. Why not?
I have no idea. It's a great question. It's a great question because, why does it recover even after a year or 2 years? It may recover. And the question is, why did it take so long? So I think you get an immediate reduction in vital capacity for about 3 months. I don't know if that's post-op pain or muscle strength, but you start getting stuff back by then, but you still don't return to normal in a lot of these kids. I think, and I don't want to spend too much time with this, but I'll just say I think that we've analyzed this in a wrong way. And I'm looking at this much more carefully with the pre and post fusion changes in lung function by looking at the number of children or the proportion of children who actually don't experience that compared to those that do. It's not uniform. And so by looking at the proportion that don't have that decline, we might learn something about why that happens. We're not there yet.
Thank you.
Dr. Alaa Azmi, you presented many cases with your proximal anchorage are screws. Although in the past, since many years, I used to found you putting rib close. So do you shift to screws in the upper anchorage as upper anchorage?
Yes, well, for the APC technique, I shifted in my technique in some issues that I would rely on screws more than hooks because of two things. The hooks on the ribs, they restrict the motion of the cage, and sometimes I see after 5 years that there is some fusion in between the ribs. So I restrict it now to the thoracic kyphosis or severe kyphosis, like what you have seen, or a case that have severe osteoporosis that the screws will dislodge. Beside that, when you put screws, you are in more alignment and more control of the spine than in the hooks. This is one thing. The other thing, I'm now shifting from 5.5 titanium rods to 4.75 cobalt chrome because of two things. It decreases the metallosis, which we are always concerned with titanium, and also biomechanically speaking, in the literature, it is equal to the 5.5 titanium rods. The third thing is that you usually, when you use the tethering, I use the 5.5, even in a 5 or a 4 years old child, I use the 5.5 rod for tethering. Even if you use the 4.5 rod proximally or distally, that's fine. But for the tethering, use the 5.5 rod, even if you put 4.5 screws, but with the 5.5 rod system. These are the things that I changed in my surgical techniques with the APC, because, you know, I realized that the major issue in the APC technique is that you are controlling the apex through modulation that will correct the spine spontaneously during the growth. And the most important thing is that crankshaft phenomena. Actually, McCarthy said in a paper that he published in 2017 that 62% of his Sheila had a crankshaft. Because you fuse the spine, you stop the growth posteriorly, but you don't stop it anteriorly. So you stop the height. And the modulation with the controlling the apex through the modulation, you don't stop the growth posterior. So you decrease the crankshaft. And actually with our study, I did more than 49 cases with the APC technique after transition and growing rods. And I realized that we have less than 30% of crankshaft. So it's nearly half. These are the things that I changed.
Thank you so much, Dr. Alaa. I think we don't have any more questions, so we'll continue with our scheduled program. And the next speaker will be Professor Dr. Mahdi Bassi. Dr. Mahdi Bassi is an active spine consultant working in Saudi Arabia in Sulaiman Al Faqih Hospital, and he's chief of the orthopedic department in Al Faqih Medical School, and he is the AO Spine Program Director at Al Faqih Hospital. Dr. Bassi will present a talk regarding how to avoid complications in growing rods. Dr. Mahdi.
السلام عليكم، كيف الحال؟
عليكم السلام ورحمة الله وبركاته. تفضل دكتور مهدي.
Thank you for inviting me for the ESA 2021. We are just gonna go with at the beginning. We are gonna talk about the introduction, concepts, obstacles. Some of the points which I'm gonna mention now is very important because it will summarize the concepts of the growing roads, also as well some of the obstacles which we are facing and how to avoid it. So usually we start when we start the conservative treatment, we found that it's not really sufficient, especially when we are talking about non-neuromuscular EOS, juvenile, and IS with the rapid increase of the deformity. So the traditional surgical correction didn't work, and it has many complications. So that's why recently there's many modalities of growing roads techniques that can do two things: controlling the direction of the growth while keeping some of the flexibility, and give the growth ability to continue in a proper direction. The obstacles when we do a fusion, we are changing the dynamic relation between the vertebrae, which determine the magnitude and the progress. So this is again the aiming is we want to preserve the growth potential of the spine. Meanwhile, we want to redirect the growth to the expected shape that can help us later once we are reaching the target age and the growth that we can go with definitive surgery. So at the beginning, the brace and casting, it was a solution, non-operative. Both of them, they have to be repeated every 2 to 3 months, the cast over the period less than a year. That can give a limitation. When we look at the complications of the non-operative, mainly the issues was skin irritations, pressure sore. It's affecting the respiratory, cause respiratory difficulties, and also rib deformations. So the surgical methods, historical, it has been started by Harrington. He was suggesting about surgical destruction without fusion, modified by Moe, subcutaneous, and then by Blackmore. And all has been documented that the curve correction about 30%, and the overall complications for all type of complications, it's about the average 24%. And you can see here in the X-rays, there's different techniques using a single rod, double growing rod techniques, and the traditional growing rods. It gives a lengthening, and as you have heard today from the lectures, there is some they go twice a year, 3 times a year. It depends, I think, for the surgeon preference who prefer to do the destruction. To me, I think minimum twice a year, it's very important. If you do it 3 or more than 3 times a year, I don't think it will cause a difference between twice and 4 times a year. So because of the issues of destruction, there is many ways and many surgical techniques has been in the market, starting with Schiller techniques, Falkers, compression-based vertebral body tethering, spinal fusion, Vector, and the magic rod. These different techniques, some of the studies starting from 2005 till recent 2 years ago, they are talking about using 2 instead of 1, using the 2 rods on concave side. They have been came out with the outcome of average, usually from T1 to S1 lengthening. This can increase about 1 to 2 centimeter per year, with 48% of complication by any nature, and some of them, about 17%, they require surgery. So that's why using double rods, 2-side convex and concave, I think it is very important. And because of the modification of the rods and the techniques and the idea, also the fixators itself has been modified, like the hooks, screws, transpedicular screws, using a claw technique formation, using screws, and also supported by cage hooks, like our colleagues, they present cases interesting today. So all these techniques, the idea of it's redirecting the growth of the spine. Also, not just only concentrating on the spine itself, also we have to consider the chest and the ribs as well. So bilateral strong fixation, it's our target. Progressive correction using telescopic construct, this is the idea, and trying to use as much minimal invasive approach, surgical approach, will reduce the complication rate. Vector and magnetic rod is an idea that has been used. I have used Vector for a few cases. I had the problem with the Vectors because the proximal, usually we are depending on the ribs, and I have few cases with the broken ribs and failed. That's why I pulled back from using the Vector, and I was considering using the magnetic rod recently. Magnetic rods, it's only one company so far that having the technique, to my knowledge, and it's from Nevasiv, and it has been licensed in Europe since 2009 and FDA since 2017. It's very good with the progressive or severe EOS beside the failed non-operative cases. So our aim to control spine deformity until the sufficient spinal and thoracic development has been occurred. The contraindications, patient less than 2 years of age. For me, I think recently I'm looking at the size of the expandable part, and I think the age is not important more than if you are able to insert the magic rod or not. The sizes, we have two different sizes, 4.5 and 5 millimeter rods, depend on the size of the patient. Also, the rod lengthening zone, because there's 270 and 90. So if you have more than 70 millimeters and above, I think this is a marker. You can use the magic rod. I prefer this more than age limitation. There is two types, standard and offset rod orientations. If you are using double rods, then you need the offset, and it can give bidirectional distraction. Initial netting is very important. What I'm doing usually, I zero the lengthening of the rod and try to do distraction correction during the procedure, getting the best correction and the distraction. Once I have it, I just reduce the distraction about 2 millimeters, so I don't do over distraction to avoid any screws pull out or hardware failure. So some of the studies has been published, and they found that there is a significant improvement of the cup angles. Double rod construction, it's better than using a single rod. Pulmonary function for a limited, there's some improvement, but usually it's limited as mentioned before. And still it's a big question why, like the question just discussed it 5 minutes ago, why with the correction of the ribs, expansion, the vital capacity is better, why they don't perform well? This is still unanswered question. The downfalls, once we have the thoracic kyphosis, this is one of the challenging, and because of the rod is big in the middle, the torque itself, it's very hard to put a screw in the middle to improve and help in the thoracic kyphosis. So the lengthening, when we compare Magic and TGR, they have similar duration of follow-up. Magic can do about 5 centimeters in lengthening. TGR can give better. Device failure, similar with the study it shows, and there was a published that cost effect by Nice in 2014 that the Magic rod it's a cost effect after third year. You can see the resting and hardware failure and the breakage can happen. The suggestion, if you suspect, you can use X-ray. If it didn't show up, especially from inside the actuator itself pin, you can use either ultrasound imaging. It might help to show and indicate that there is a fracture of the actuator. Metallosis is one of the challenging problem and complications, and I think there's one of the slides I will show you now. Before we go to that one, the power of the distraction. The power of the distraction with TGR, it's 142, but once it reached the 10th trial of lengthening, it jumped to be 608. And I think that's why the ribs cannot stand and break once you are passing 8th trial of lengthening. Whereas the growing, the magic rod usually almost most of the time it maintains between 180 to 200 Newton, and it doesn't go extreme like the TGR. And the period effective for the magic rod, it can go up to 35 months of trials, and it can give up to 22 millimeters of lengthening. Safety issues, as I mentioned, it's very important if you start to consider to using the growing rods, you have to look after the serum concentration of some of the metals like titanium, niobium, aluminiums, vanadium. They found it in some of the studies, it become very high in the blood of the patient, but we don't know until now what is the effect of it once it is high. It didn't show any symptoms. So I think now the FDA, they are revising the approval again for the idea of the growing rods. They want to study more about this in the blood and the effect on the children as well. I think they are trying to now modify the system like Magic X or Magic 2. For cost effect for the system, in Hong Kong, sorry, they found that it become cost efficient after the 4th year of continuous treatment, whereas in the United States up to 6 years. When they did the study between the two systems, they couldn't find any psychological difference between the TGR and the Magic Rod. You can see here, this is same child on both sides. I used the brace to correct, and I used the Magic Rod, and you can see the difference here. It's very important. I notice, you see here, I'm using a 4.5 screw in that child, but on the right side, you can see the positioning, it's efficient, but during the follow-up, it pulled out. And I think one of the suggestions I was considering here, it's using a double cortical screw to hold, especially in the proximal, and use a 3 screw in both sides. It could be a solution. Besides, you have to bend the rod more to compensate the kyphosis. By this way, you can avoid the failure of the proximal area and pull out of the screw. As I said, if you look here, you can see the diameter here, it's thick, so it's not easy to put tethered screws or screws that can correct the kyphosis. But with the stretching, you can see the spine become more straight. The patient lost some of the thoracic kyphosis and lumbar lordosis. It's more to be straight, and this is one of the challenging, because either you do a less correction or you can go with more distraction, and by this way you can lose the shape, or the sagittal shape of the spine, beside also the screw proximal pull out. Beside, the screws cut through here and the rods, and you can see here one of the cases which make me again reconsider making the proximal screw using the most low profile screws, and at the same time try to make the rods the exit from the proximal screw less than 4 millimeters. By this way, the friction become less and even less painful for the patient. If you look at here, this case, you can see that this child is very short, but here I use the 70, and still you see there's enough space that I can, even if he is even more shorter, I can manage to install it. When you look here at the proximal, I managed to make the screw and the rods more in kyphotic shape to match the shape of the patient. And this case now, so far, he's doing well. He's growing, and the rod is getting in position. And I think the reason, because I use the concave conversion technique, double cortex, 3 screws from both sides, and I bend the rod more to match the shape of the proximal area of the thoracic. And you can see here, this one, when I use 2 screws at this area, I had a problem with the broken rods here in the proximal. And I think one of my problem here, I bent a little bit at the junction. I used the maximum correction of the rod here, and I did more distraction, and also the cantilever problem here. It helps, and the rotation, it helps to make more stress at the junction between the rod, the 2 diameters of the rod, and that's why I lost the rod at this level. So at the end, use proper diameter and length of the screws and the rod. Try to use a low profile as much as you can. Bend the proximal part to avoid pull out. Proximal screws has to be double cortex, and try to use a conversion way as much as you can. Sometimes I'm using the navigation in small children because it's very difficult to find and match. You can use in-out-in technique as well. Keep the actuator pin close. Do distraction as much as you can. Once you reach the maximum, just reduce little bit, about let's say about less than 5%. By this way, you avoid over stretching and tension to the soft tissue and fatigability to the screws. Wait about 3 to 4 months before you start to do the initial expansion, because you achieve more than required during the procedure. By this way, just give the time for soft tissue to heal, compensation, and then you can start the distraction. Cross links to avoid rotation. I'm thinking about it. There is studies, also presentation before here. They mentioned about the cross link. I think I would consider the cross link. It might help also to prevent failure. Avoid bending the distal part close to the equator pin to avoid breakage, like the case you have seen. And usually follow up with X-ray. Blood test, I think it's very important. If you decide to use the magic rod, I think it's better to do a blood test. Now, meanwhile, we are waiting to see what is the complication while finding titaniums and all the metals in the blood in the children. Is it safe to be used or not? Use the 3 screws if you decide to go proximal and distal. Sacral screw is very important. Once if you are very close to L5. Bone grafting, I prefer once I put screws proximal and distal, I do decortication, and it's not harm to fuse segmental fusion proximal and distal. This can help to maintain the screws and the rod, and it reduces the pull out and failure. Thank you very much.
Thank you so much, Dr. Mahdi El-Basi, for your presentation, and we'll keep the discussion at the end of this webinar. And the next speaker will be Dr. Colin Nadi. Dr. Colin Nadi is a spine consultant in London and working in Oxford, and he will highlight how to deal with severe early onset scoliosis cases. Dr. Nadi, we are happy to have you between us. Please go ahead and show us your experience.
Thank you. Thank you for inviting me to this prestigious meeting. And I will go through this talk. So the aims are as follows. I'm not going to bore you with any detail about heroic surgery, but what I'm going to try and do is take you through the principles that I use in terms of the preparation, surgical choice, minimization of risk, and the promotion of physical and mental well-being of severe cases of early onset scoliosis. So we're all familiar with the definition, so I won't take any time there. From a historical perspective, in terms of the treatment, we've been through the different phases of early non-instrumented fusion surgery, then to Harrington rods with and without fusion, a segmental fixation technique, and then to some of the more modern methods. But I think it's fair to say that with each of these methods of treatment, there have been problems, and Bob Campbell has highlighted the issues with respiratory insufficiency syndrome and the detrimental effects that it has on subsequent outcomes for these children. And we now know that those children who end up with thoracic insufficiency syndrome are some of those who have the poorest quality of life in the pediatric age group when it comes to medical comorbidities. So there, over the years, and a lot of the different techniques have been mentioned during this meeting, from bracing to the operative methods of distraction, growth guidance, and now more recently, the compression-based techniques in dealing with what is a very challenging problem. But despite all the advances and increasing knowledge base, there is still a very high complication rate with this patient cohort, no matter what we do. And we know that they're a very young group. They will require repeated operations. And each time we operate on them, the risk of complications goes up, even with some of the newer devices, which are game-changing technologies, but still have problems. So the first thing in terms of the preparation that I'd like to stress is that this is a multidisciplinary team event. You cannot do this as a standalone spinal surgeon. You must have a good team around you and a highly specialized team at that. So this slide here just reiterates the sort of setup that I work with in Oxford when it comes to dealing with some of these very complicated cases. The other thing is, from a surgeon's point of view, you must plan preoperatively, X-rays, MRI, CT scan. So most of my patients will have a CT scan to define the bony anatomy preoperatively. An MRI scan is our standard of care, and also X-rays, which would have been done along the management pathway anyway. Similar to the adolescent age group, you've got to get your level selection right, because we know that if you get this wrong, there can be problems with spinal balance in both the sagittal and coronal planes. You then have to select your implants, decide how you want to correct the curve, because even in the early onset group, you have to think about not just the forces that the implants apply to the spine, but also what the spine does to the implant. So for instance, with the magnetic growing rods, the cantilever technique doesn't work so well, because then that means that you place the rods in under tension, and there's a higher likelihood that there'll be proximal or distal screw pullout. You also have to think about your perioperative etiquette in terms of prevention of infection, prevention of pressure area complications, and also wound surveillance afterwards. And the key goal is that you want to get these children back to their normal lifestyles as quickly as possible. So the follow-up involves various stakeholders to ensure that all their needs in the recovery phase are met. So I'll just go through a case of mine that I feel encompasses all the principles that I've just spoken about. So this is a case of a 6-year-old who was referred from another tertiary center in the UK with an initial diagnosis of Stickler and de George's syndrome. He'd been treated with a Vector and then a growing rod construct. So the family brought him over because they felt that the treatment wasn't progressing as much as they'd hoped. Their child was still very small for his age. The curve was progressing, and his original diagnosis had been revised to campomelic dysplasia. So limited spinal growth was a great concern, and you can see that the prominence of the metalwork and the subsequent PJK was also beginning to worry the family. So I had a discussion about the varying treatment options and the advantages and disadvantages of either further growing rod constructs or even considering a fusion. A CT scan at the time showed that most of his spine on the right side had auto-fused. But after a lengthy and detailed discussion with consideration of all the treatment options, the parents opted to go for the magnetic growing rods, even though the kyphosis, as one of the distinguished speakers earlier had said, is a relative contraindication. But they felt, considering their child had been through so many operations, this was new technology that sounded very promising. They were willing to take the risk. So in May 2014, he had magnetic growing rods inserted. Within a year, the proximal anchors dislodged, requiring revision surgery. And he was 7 years old at the time. So they were revised. And then within another year, the anchors were prominent again. But on this occasion, I took the decision not to lengthen him, as clinically, despite the metalwork prominence, he appeared to be progressing well. However, by the summer of 2019, the curve continued to progress. We didn't seem to be making any headway in terms of the prominence of the metalwork, and the skin was at risk of breaking down. So after another lengthy discussion with the family, I opted to take out the rods and apply halo gravity traction. Now, the image on the left where you can see 4 screws, I usually, if I do take out the rods temporarily, I usually leave the foundations in place, and that's simply to make it easier for revision surgery in terms of gaining purchase on the spine. So that's a standard technique that I use for revision cases. So he was in halo gravity traction for 3 months, 2 to 3 months. And as you can see, there's been a reasonable correction in the coronal plane. although I appreciate the rib cage deformity. And in the sagittal plane, although there is still a prominent kyphosis, it's certainly a more rounded appearance to the compared to the angular kyphosis that he had on initial presentation. And on this occasion, I opted to use a single 5.5 millimeter rod with sublaminar bands. In hindsight, I could have used a few more bands, but at the time, because of concerns about skin fallibility, I opted to use as few bands as possible. So by, well, actually within a week of that surgery, his wound broke down. Fortunately, no infection was identified, but then we were faced with the scenario of whether this was a lost cause and should we take out the metalwork. So we had a roundtable discussion, and by this time he was 11 years of age as well, and so again, the discussion about whether he would be suitable for a definitive fusion arose. But after discussion with the family again, they were very eager to continue with the magnetic growing rod treatment. And so we persisted. So the wound settled down. There was no infection. And then he was okay for about 2 years. And then in the early part of this year, he represented with a failure. So as you can see, the bands have broken and the proximal foundations have dislodged from the spine. He also, on this occasion, had an infection. So there was a discharging wound. And as you can see, there's been very little distraction of the magnetic growing rods. So at this stage, despite their disappointment, the parents were insistent that we continue with the magnetic growing rods, as they were very keen to optimize their child's growth potential. This I felt would put me in a really, really difficult situation, because I know one of the previous speakers had mentioned that age shouldn't determine whether you use the magnetic rods or not. But in terms of weight, there is a cutoff weight at which the rods start to diminish in intensity in terms of their distraction force. And we've published on this previously. So here he is at the age of 13, has gone through nearly every growing rod construct possible. And, after multiple revisions, has represented again with a failed device and an infected wound. So just to take a pause and just to see in terms of what his journey has been like, and this typifies what you would see with children with severe early onset scoliosis. So the rods were put in May. We had 2014. We had a few good years. Despite after the complications in 2015, we had a few good years until 2018, when the anchors were prominent. He was getting a backache with the skin at risk. By June 2019, I decided to take out the rods, put him in a halo. Before I did this, I actually obtained a CT of his head and lumbar spine, the CT of the head for the halo gravity placement, and the CT of the lumbar spine to define the bony anatomy. All these procedures had to be done under a general anesthetic. I then took out the metalwork. He was in the traction for 2 months. And then 2019, I had to reinsert the rod. Within a week of reinserting the rod, the wound had broken down. Fortunately, there was no infection on that occasion. although in hindsight, maybe there was a brewing infection. By February 2021, he'd represented again, and on that occasion, I decided to wash the wound out, debride it, and remove the rod, and give him a period in a brace to allow the infection to settle. And all through this process, I was working very closely with my infectious diseases colleagues, who happened to be the same team who developed the Oxford AstraZeneca vaccine. So the pressures, at this stage were almost multifaceted. On the one hand, we had parents who were very keen for their son, who's disproportionately small for his age, to optimize his growth potential. On the other hand, we had a 13-year-old boy who's now approaching his teenage years, who wants to look and feel like his peers at school and is starting to become more self-aware of his body image. But then on the other hand, if you look at the images on the left there and on the right, his growth parameters were all well below what you would expect for a 13-year-old. He was well below the 10th centile, both for height, weight, and even his BMI status were all well below what you'd expect for a 13-year-old. So it was, really, really difficult, because like I said, the parents were really pressurizing me to put in another magnetic growth rod. Fortunately, our equivalent of the FDA suspended the use of the magnetic growth rods because of technical design fault. So that gave me some breathing space. But then the crucial and one of the other crucial things was that we then had to get a clinical psychologist in, because here was a 13-year-old boy who'd spent most of his childhood in and out of hospitals, and it was starting to have the predicted effects. So again, we brought in the clinical psychologist to work alongside us to help him, not just him, but also the family through this very stressful period. So I then started to think, well, I didn't think that the growth rods, any growing rod construct, would be suitable for this child. So I needed a get out of jail card to present to the family, so that I could give them a solid reason, not to use the growth rods, and perhaps now consider moving on to a more definitive procedure. Bearing in mind, he's small for his age. The spinal fusion has the obvious disadvantages. But I think what swung it was the natural history. So what I always teach my fellows is, with early onset scoliosis, more crucially than many other areas of surgery, you need to understand the natural history of whatever condition you're treating. Because once you understand the natural history, then you can tailor your treatment to adapt around the natural history. So this child with campomelic dysplasia was never going to achieve a full growth potential for a 13-year-old. His curve was likely to continue to progress even with growing rod treatment. And after multiple surgeries, multiple hospital admissions over the years, I think, psychologically, he was getting to the end of his tether. It was causing family stresses. So I think that a definitive fusion was a very reasonable procedure. So after much discussion, this is what I did. I fixed him in situ, and this was actually a couple of weeks ago. Yes, he retains a sagittal plane deformity. Yes, he's of a short stature, but for him, that is his designated, if you like, final appearance. So the definitive fusion was again done in conjunction with the plastic surgeons, who made sure that there was an adequate soft tissue reconstruction to make sure that this time the metalwork doesn't break the soft tissues down. So this is just one example of a multifaceted approach to dealing with severe cases of EOS. This is another case which is at the other end of the spectrum, where I have a 10-year-old girl who had an initial hemivertebral resection at the age of 2, then represents at the age of 10 with recurrent progressive deformity, RISA grade of 0. So the question is, and on her growth chart, unlike the other patient, she was actually well within the normal range for her age. So the question here is, well, in view of her remaining growth potential, do I just do a definitive fusion because she's now 10 years of age, or do I re-resect the hemivertebra and try and balance her spine? So just quickly to wrap up, I elected to just re-resect the previous fusion mass and do a short instrumentation to rebalance her spine, which was very good immediately post-op. She's almost a year post-surgery now. And so there has been, as you can see, almost recurring deformity. So she's still very well balanced, but I do wonder whether I should have just, bitten the bullet and gone long anyway. And then just as a final slide, this is a neuromuscular case. We've written this technique up when you have the very sick neuromuscular patients with severe comorbidities, which will prejudice surgical outcomes. We've developed a modified Wiltse approach using a 2-incision technique in Oxford, whereby you can instrument the whole of the lumbar spine into the pelvis through a Wiltse approach, and then with a second short proximal incision over the thoracic spine, place pedicle screws, and then thread the rods submuscularly to connect the construct below. We do have a long-term follow-up, which shows that it minimizes blood loss, reduces operation time, and also reduces their ITU stay. So this is another technique that we use. And we also, as part of our preoperative planning, counsel the families and say, yes, there is a risk that the bridging rods may break in the future, but the operation to correct that is a much smaller procedure than doing a large instrumented fusion. So as you can see, I've instrumented all the levels in the lumbar spine, including S1 and the pelvis. So in summary, early onset scoliosis is a very challenging area of spinal surgery. The key decision-making factors are usually varied but patient-specific. The key performance indicators are growth, radiological, physical, and mental well-being of the child. The surgeon's expertise and awareness of their natural history is critical in successfully managing these patients. The good thing is this is an evolving specialty with lots of opportunities for further development. And thank you for your time.
Thank you so much, Mr. Colin, for your presentation, and good luck in your surgery. I know that you have busy schedule. Thank you so much for supporting the Egyptian Scoliosis Society. And we will continue with our program. The next speaker will be Dr. Vinay Saraf. Dr. Vinay is a professor of orthopedics in Graz Medical School in Austria. Dr. Saraf will present 2 lectures covering the muscular dystrophy and the spastic scoliosis cases, 2 tough cases that we can meet, and we hope to learn from Professor Saraf his experience. Dr. Saraf, kindly unmute yourself and go ahead. Thank you so much.
So good evening and hello to Egypt. Thank you for giving me the opportunity to present our cases. I'm working in the pediatric orthopedic department in the University of Graz in last 25 years, and we are doing surgeries, pediatric spinal surgeries in 15 years. So there are a lot of senior surgeons, and I'm looking forward to positive feedback from the senior surgeons. The first talk is about management of scoliosis in muscle dystrophy. If we consider muscle dystrophy as a cluster of disorders, there are lots of different muscle dystrophies, but generally the patients who make up the major bulk are 2 disease groups. The one is Duchenne muscle dystrophy and the other is the spinal muscle dystrophy or SMA. The general disease progression is that once a scoliosis begins, it's usually with loss of ambulation and progressive loss of trunk stability. And once they lose their trunk stability and the scoliosis develops, the progression of neuromuscular scoliosis in dystrophic children is almost 90 to 100%. Duchenne muscular dystrophy, it was first described by Duchenne. He was a physician in France. The incidence is about 1 to 3,500 male births. The diagnosis is principally clinical and it can be supplemented by genetics. It's an autosomal recessive disorder, so it's very important to screen the sisters or other female family members who could be silent carriers of the disorder. Corticosteroids have been documented to have a role in maintaining ambulation for up to 2 years longer and is internationally established. However, there is no proven role for the role of corticosteroid therapy after the loss of ambulation. And the primary caretaking goal should be regular evaluation of cardiorespiratory function. The first loss in pulmonary function is often detected in non-REM sleep in early morning hours, so polysomnogram is crucial and important, particularly after the disease progresses. Due to improvement in pulmonary care, pulmonary assisted ventilation, and also stabilization procedures, the life expectancy for Duchenne muscle dystrophy patients has improved. Before 1980, the approximate life was around 20 years, and in the last 15 years, it has been subsequently increasing. Are there new medical management strategies for Duchenne muscle dystrophy? Just a minute, I have to put down here. There are experimental drugs which are available for a small group of patients with Duchenne muscle dystrophy who have the nonsense mutation. These patients constitute around 10% of the cases worldwide. The diagnostic is genetic, and in these patients, there is an experimental medicine drug available where randomized controlled trials are still going on, and the results are to be concluded in the end of 2021. I have given the details of the medicine and also the doses for the younger surgeons who would like to look it up. The second group of disorders which we will be talking about is spinal muscular dystrophy. The diagnosis is also clinical, confirmed by genetic screening. There are basically 4 types of disorders, and the breakthrough in the care of this spinal muscle dystrophy was identification of SMN1 and SMN2, the survival motor genes, which triggered genetic engineering and genetic research, and which has drastically changed the medical care of this disorder. There are currently 3 medicines available in the market. The first one to come in the market with FDA approval in 2016 was Spinraza, which is indicated for SMA type 1, 2, and 3. The medicine is given intrathecally with initial 4 loaded doses in shorter intervals and then a maintenance dose every 3 to 4 months for the rest of the patient's life. I have documented the approximate cost. A Spinraza treatment in the first year costs around $750,000 US, and after that it's around $375,000 every year, likely for the rest of the patient's life. These drugs have been approved by the majority of the insurance companies in Europe, so it's a factor which we have to consider when we are managing patients with spinal muscle atrophy. The second drug which has been approved in 2019 is Tolgen's SMR for patients with specific mutations of SMN1 type and also with the severe type who have more than 3 copies of SMN2 mutation. This is given as a single intravenous infusion and it is covered with corticosteroid for almost 3 to 4 weeks to protect the liver. The moderate price of this drug is around $2 million US. It is important that if you consider the long-term cost, then this medicine is much cheaper and is less invasive than the primary medicine which I mentioned, Spinraza. And the third medication which is recently come in the market is with FDA approval in August 2020 is Risdipalm. This is recommended for infants 2 months to 2 years of age. There are no long-term reports. There are no suggestions or indications for children over 5 years. So it's a very restricted group of patients, usually children with early diagnosis and SMA type 1 and 2. Does conservative management have a role in management of muscle dystrophies? Very limited. Basically, it's very limited in preventing progression. You could win a few years. The basic facets have already been talked about from my previous speakers. You have physiotherapy, initial early start with breathing exercises and pulmonary physiotherapy. In Europe, hippotherapy riding therapy is very popular. We try to maintain the trunk balance as far as possible. We try not to overprotect the children so that they lose the balance which they have. We try to adjust and optimize the seating adaptation. Spinal orthosis are generally not well tolerated by patients with Duchenne muscular dystrophy. Works for a few years with smaller patients, thinner patients with spinal muscle atrophy. Nice plain standing frame and stretching exercises for the extremities are important, particularly in the first growth period. And ergotherapy is also very essential for assisting in aids for learning, transfer, and home care. What are the indications for surgical stabilization in muscle dystrophy? There are no standard indications, and according to me, the progression of scoliosis ankle is not the most important criteria. The most important criteria is to begin with first trunk decompensation, to check the patient regularly, wait, and with the first reduction or decompensation of cardiopulmonary function, talk with the pediatrician, and decide for optimal timing for the surgery. And this has to be cooperated with the pediatric neurologist, cardiologist, and pulmonologist, as well as the pediatric genetist to know the natural course of the disorder. These are basically high-risk surgeries. They have to be well explained to the patients. The indication has to be well explained. The timing of the surgery has to be well explained. And to be appreciated, I don't operate patients where the family doesn't want surgery or doesn't appreciate the situation or ideal timing for surgery. We have a very extensive preoperative workup here in Graz. We admit the patients for 1 week for a preoperative checkup, and we do quite extensive preoperative workup with a complete blood count, reading profiles, if necessary, contact with the hematology outpatient, cardio and pulmonary checkups, if possible, lung function or blood gas analysis, polysomnography in almost all patients, even if they don't have any respiratory symptoms. If they have minimal respiratory symptoms, they are trained with mask-assisted ventilation or cough assist before the surgery. The pediatric neurologist is essential by patients with epilepsy. Neurosurgery is essential if there are lying shunts in some patients. Gastroesophageal reflux is very common, so we do a 24 hours impedance pH metry, and if necessary, they get medical or surgical treatment. We try to evaluate the bladder function with the cystometry and urine culture. The physiotherapists work throughout the week with the patients, training them for on-block training them how they should move, how they should sit up after the surgery, training them for breathing exercises to prepare for the surgery. Ergotherapy, I already mentioned, is essential for optimizing the activities of daily living. And as my previous speaker mentioned, a psychological evaluation of the family is very important. I will go through 3 or 4 cases just to show you the spectrum of patients we have here in Austria. This is a girl with spinal muscular atrophy type 2 at the age of 10 years. As you can see, she's quite obese, and so there was very less chances of some conservative management for her. And so we just waited till fusion of the triradiate cartilage, and then we did a long fusion. This is one of my earlier cases, so I didn't quite go up to the upper thoracic spine. So you see on the AP X-ray that she has a head tilt on the right side, which you also see in the clinical picture, but luckily her sagittal profile is quite acceptable. And this is her 15 years after surgery. She is now a young lawyer and independent. This is a second patient also with spinal muscular atrophy. She was referred to us from another city. She came quite late, but as also the previous speakers have mentioned, correction of scoliosis in muscle dystrophy is not much of a problem because basically the muscles are very flaccid. You do have soft tissue and fibrous contractures, which are relatively easy to correct. I prefer to go for very high implant density because the bones are very osteoporotic. And in muscle dystrophy, I prefer not to fuse to the pelvis because the pelvis is very osteoporotic, and for transfer and mobility function, I have concerns regarding this. This is a patient with spinal muscular atrophy. His older brother we operated at the age of 14 with conventional fusion. He had a more severe form which could not be arrested with corsets. And so at the age of 7, we decided to do magnetic growing rods. Also in muscle dystrophy, magnetic growing rods work quite well. We prefer to take more anchors proximally, as you see in the postoperative x-rays, because of the osteoporotic bone, and so that the screws have a better anchoring. Duchenne muscle dystrophy with 120 kilos at the age of 17, no ventilation support needed because he has a nonsense mutation and he has a mild curve of the disease. So regarding the discussion whether to fuse the pelvis or not, just imagine moving the patient with a lift for daycare. And also that's why in this patient we did a long fusion and we avoided fusion to the sacrum or to the pelvis, and we stopped at L5. This is a patient with 14 years old. Duchenne muscle dystrophy is already in the atrophic disease where he's decompensating very rapidly. The family insisted for surgery, and these are the postoperative X-rays. I prefer to give a spinal orthosis with a large recess for the abdomen for respiratory purposes, and I prefer to wear it for at least 6 months during the daytime till the metal is well integrated with the bone and the fusion has started progressing. What is the approach to take when you are doing conventional posterior fusion in Spinraza patients? Because they need this intrathecal infiltration every 4 months. It is essential because it stops the progression of the disorder, spinal muscle dystrophy. And so we do a combined approach of a conventional dorsal approach for the thoracic spine, and for the lumbar spine, I do a wheelchair approach. And here you can see the quadratus lumborum as it is exposed, showing the lumbar screws, and the thoracic screws are put in the conventional way, and the lumbar spine and the lumbar fascia are surgically not touched, so the pediatrician has less problems with future infiltrations intrathecally. So the take-home message is I have written generally for neuromuscular scoliosis, there are no standard management protocols like in idiopathic scoliosis. You are dealing with a large spectrum of disorders, a wide range of mental and physical affection. Management should include home care, physiotherapy, occupational therapy, schooling, transfer, daycare, management evaluation preoperatively. Evaluate the expectations of the patients and the family, like Mr. Colin also mentioned in his talk. Does it correlate with the surgical and non-surgical goals that we have as doctors? Evaluate the situation of the family and healthcare setup for the patient before surgery, and if necessary, improve the social setup also before the surgery. Aspects in conservative management. In ambulatory patients without retardation, conventional treatment is similar to idiopathic scoliosis. Try to motivate them for sports if they can. Do scoliosis specific physiotherapy. Motivate overhead sports, swimming, riding, orthosis if the COP ankle is over 25 and they have good lung function and they tolerate it. In muscle dystrophy, we did occasionally use corsets to win a period for 2 to 3 years, but it was always with a reference to the pulmonary outpatient. Ambulatory patients with retardation cannot do specific scoliosis specific therapy, so the main aim there is to motivate mobility, motivate them that they keep on walking with simple overhead games, spinal orthosis if they tolerate and when indicated. For non-ambulatory patients without retardation like cerebral palsy or muscle dystrophy, try to optimize the seating back support. In the first growth spurt, use standing frame to stretch the psoas hamstring particularly, motivate upper extremity agility and training because this is what they are going to need to use the wheelchair, to use the electrical wheelchair, and also to use the computers. Non-ambulatory patients with retardation are very limited chances of conservative management. Try to optimize seating, optimize the nutrition. Spinal orthosis are also generally not well tolerated by this group of patients. General points regarding surgery by muscle dystrophy: progression of the underlying disorder and life expectancy are important. So it's very important to have an open communication with the pediatricians, particularly the pediatric neurologist who knows more about the basic disorder. In muscle dystrophy, planned stabilization of the spine with the first decompensation of pulmonary function, the angle of the scoliosis is not important. Hip subluxations and dislocations, if painful and causing difficulties in daily hygiene or in getting a good pelvic fixation for seating, I prefer to operate the hips first. If the patients are mentally well and have a good condition and good cognitive function, we prefer to reconstruct the hips with pelvic or femoral osteotomies, and patients with severe mental handicap, option is a salvage procedure with resection of proximal femur. For the preoperative assessment, I already mentioned in the preoperative week, particular point is that our preoperative consent for the surgery, we document the time of the talk, and it's generally 1 to 2 hours for the surgeon and half an hour for the anesthesia. We talk about everything. We don't, and very realistic and down to earth. So it has to be well talked. The family should understand the situation and then agree and go for the surgery. Intraoperative management, usually there are extended fusions, long fusion. The basic functional problem is, irrespective of etiology, is that they don't have any trunk control. So you need long fusions. Meticulous blood management is important. Many of them have bleeding disorders, so careful hemostasis during surgery. We use thrombin glue quite frequently and use a cell saver. Neuromonitoring is mandatory. We have to tell the neurophysicians that in muscle dystrophy, maybe you don't get the motor potential so well, but the sensory potentials are still there to monitor the spinal cord. Postoperative intensive care is mandatory. Many patients require stabilization of blood pressure, clotting factors, and assisted pulmonary ventilation, particularly for the first few days. We have started using air mattress to prevent pressure sores since the last 10 years, and we are quite happy with the use of it. I already mentioned I am personally very skeptical about extending the fusion to sacrum or the pelvis in muscle dystrophy patients because of osteoporosis and to permit stress-free transfer for these patients. Our postoperative routine is that generally in the first year we check them up with x-rays and clinical checkups every 3 months. In the second year at 6 months interval, and then directly at 3 years, and after 3 years x-rays every 3 or 5 years. I prefer to give a postoperative orthosis for generally 6 months to 1 year, postoperative to be worn during sitting and in daytime, and adaptation of sitting wheelchair and transfer as necessary. Like I said, there are a lot of specialties you need to plan these surgeries, and there has to be one person who coordinates all this, and I feel it is the responsibility of the orthopedic surgeon who is going to operate the patient to communicate the management of neuromuscular scoliosis, the conservative management, the perioperative care, and also patient care at home, school, and daycare center. Thank you for your attention.
Thank you, Dr. Saraf. Can you proceed for the second presentation?
Okay. So the management of neuromuscular scoliosis in spasticity, some of the aspects, basically the preoperative checkup and the considerations for surgery are overlapping, so I will go through them very fastly. Basically, you have three big parts or three big, if you simplify the classification of scoliosis, you have three groups. The first is idiopathic, the second, the congenital scoliosis with segmentation and formation anomalies, and neuromuscular is a big conglomerate of many disorders. We will be talking about cerebral palsy. The main cause is a brain damage that occurs in the peripartal period of the birth. It's actually a big group of neuromuscular disorders with very diverse affection of cognitive function, movement, balance, and posture. About 50% of the children can walk independently at the age of 5 or 6, and about 50% of the children are non-ambulatory patients. And most of the patients with cerebral palsy have also comorbidities. Almost 80% of patients with spastic tetraplegia have gastroesophageal reflux, and aspiration is the most common complication. Also, a lot of the patients have epilepsy. Development of progressive scoliosis in ambulatory patients is rare. In patients with tetraplegia and absence of head and trunk balance, the chances of progression are very high, particularly during the growth spurts. Can we prevent progression with conservative treatment? The best treatment is prevention as far as possible. We can't really prevent progression. Orthosis can be used in spastic cerebral palsy patients if they tolerate it, but patients who have a lot of tonicity have also problems with orthosis, so conventional management is very restricted. For non-ambulatory patients, you can give anatomic seat support the trunk, stable fixation for the pelvis as far as possible. If you decide to go for surgery, these patients are also not really ideal candidates for surgery. So it's not something that you take out your appointment calendar and make an appointment in 3 weeks. The primary problems patient related are that the patients are mentally retarded or they are deficient. They don't understand what is going to be done to them. So you don't really have a communication with your patient. They have nutritional deficiency, they have gastroesophageal reflux, they have often feeding ports, epilepsy, and many of them also have shunts. For the anesthesia, it's also generally a high risk allergy. A lot of them have allergies. They have compromised cardiopulmonary function, which cannot be assessed accurately at times. These surgeries cause a lot of blood loss. Many of them have also bleeding disorders. They have a very precarious circulation and blood pressure. The intestinal motility is very poor, and these patients tend to go for postoperative ileus. And so postoperative management is also very demanding. For the surgeon, like I said before, in muscle dystrophy, there is no standardized surgical criteria. You are dealing with pathological bone structure. You can use the best implants in the world, but the bone structure is precarious, so you don't really have a stable osteosynthesis. You have to deal with intraoperative blood loss. Sometimes it is difficult to position the patient for surgery. Pressure sores are very common and much more common in spastic tetraplegia than in muscle dystrophy patients. They are long fusions, long surgical times are necessary. Is it then worthwhile to operate these patients? When we talk generally, whether it is spastic tetraplegia or muscle dystrophy, I am convinced yes, because these patients are going to get old. The spinal surgery may not improve their duration of life, but it definitely improves the quality of life. If they're getting old, they're getting scoliosis above 100 degrees, they get repeated pleuritis and pneumonia and pleural effusions, and so you definitely improve the quality of life with a spinal stabilization. The ideal time for surgery, like I said, it's individual according to the disorder of the patient, the underlying disease and prognosis. I always try to talk to the neuropediatrician about the expected lifespan of the patient before planning these surgeries. I prefer to stabilize the hip and pelvis first. The rest of the talks we talked about during the preoperative checkup, and we have to clarify the aim of the surgery to the patient and the family. The aim of the surgery is to maintain the mobility status. If a patient cannot sit, and if you can achieve in seating, it's an aim of the surgery. If he's sitting, you try to improve his sitting, that it is less strenuous for him. And if it's an ambulatory patient, try to maintain the mobility status of the patient. The preoperative checkup I've already talked in my first talk. The preparations for spinal surgery my rule is all possible risks which can be treated or minimized should be optimized preoperatively. Many of these children have iron deficiency. They should be supported by diet assistance or give infusion if necessary. Gastroesophageal reflux is always managed before I operate a pediatric spine, either with medications or reflux surgery depending on how the pediatric surgeons suggest. Nutritional management and diet assistance are essential, sometimes for supplementation, sometimes also for weight reduction. Subluxated hip, reconstruct or resect. Like I already told you, patients who are cognitively well going, like this is a patient I've been managing since he's 5 years old. Now he's 23 years old. He's studying music in the Vienna University, and we did a shock for gait improvement surgery. We did a hip reconstruction, and finally did the spinal surgery. So he's going to profit from these surgeries. The patient above is severely mentally retarded, is blind, he has 14 kilos with 14 years of age. He has severely, the hips have been operated several times before. In such patients, salvage surgery with resection of proximal femur is a good option to improve seating capacity and to help in daily care. I have again 2 or 3 illustrative cases. This would be a typical patient with spastic tetraplegia, but mentally very well off. He's attending normal school. He came with scoliosis. Those who are doing neuromuscular scoliosis know that by the time the patients reach the table, you are crossing around 90 degrees. And here also we prefer to do a long fusion. I avoided fusion to the pelvis. I extended my fusion only to L5. In spite of the pelvic tilt, you can correct the pelvic tilt. And if you use high implant density, usually the implants hold also quite well. These are his preoperative x-rays. Here you see the postoperative x-rays. This is another patient also with spastic cerebral palsy, very slightly retarded. He wanted to work as an office assistant at the age of 14. He came with a kyphoscoliosis with a 90-90 deformity. As you see in the 3D reconstruction of the spine, we could do the surgery and correction of the deformity with the dorsal approach with eccentric Smith-Peterson's osteotomy and radical facetectomies. I left the lumbosacral curve, although it is around 50 degrees or 60 degrees, because the patient was ambulant, like one of the senior surgeons in the previous talk mentioned. If he's ambulant, if he can walk, even if he can walk 200 meters, try to maintain this. So he is informed, like all spastic borderline cases, at the age of 20 or 25, when he gets tired of ambulating and he sits in the wheelchair, we can always extend the fusion to the sacrum and the pelvis. Would you, oh, I'm sorry. So would you operate this patient? She's 9 years old, spastic tetraplegia, tracheostoma, and a feeding tube, feeding port in the stomach. The family wanted the surgery. For them, it was a valuable family member. We did a proper checkup. We did the spine surgery first, and then the spastic was transferring to the hips. And so after the spinal surgery, we had to do a resection of the hips. 10 years down the line, she's still doing fine. She has no pain. She can sit well for several hours. And the results, the family is happy with the results. This is a patient with 16 years old spastic cerebral palsy, severe scoliosis with 16, 17 years old. That's too old for us pediatric surgeons. And accordingly, also he was very rigid. We had to do also multiple dorsal osteotomies. Correction of the kyphosis caused him a lot of medical problems. Post-operative, he got an extreme increase in lactate dehydrogenase, where the intensive surgeon was suspecting intestinal rupture, and they did a CT scan of the abdomen. Luckily, he just scraped through, and this is him after 2 years of surgery. The family is happy, but like I said, these are high risk surgery. You are walking along a very narrow lane in these patients. Would you operate this patient? Severe spastic tetraplegia, epilepsy, blindness, iron and vitamin D deficiency, osteoporosis, both hips operated several times, history of pathological fractures in the lower extremities. So is it worthwhile to operate him? So it's a very narrow border, and this has to be talked to the family very openly. The family said no, they definitely want a stabilization. And so what we suggested is we will go step by step. And at any step, if we get a feedback from the pediatrician or from the anesthesiologist, okay, this is too much for the child, then we stop the management. So we started, just as an example, in October 2015 at the first presentation. In November was the first preoperative checkup week. They diagnosed a massive reflux with esophagitis. So we started with diet, nutrition, and medical treatment for the esophagitis. After that, 3 times endoscopy, and after 9 months, the mucosa healed so that the reflux could be operated. After that, he was operated for open fundoplication. Unfortunately, he got peritonitis, so he needed a re-laparotomy for release of intestinal adhesions. Then they said, the orthopedic surgeon, okay, he's your patient, you can start with him. And in December, we did a resection of proximal femur to achieve a sitting function. And after 1 year and 5 months preparation, we could operate his spine. These are his preoperative and postoperative x-rays. An anatomical spine is not important in severe curves, but the stability of the spine. And these are his clinical pictures. If you see the last picture, at 4 years after surgery, he has been put on diet. Maybe the surgeon also needs a diet. So you don't need an assessment. You know he's doing fine. He has less pain. He can enjoy life. So their quality of life is definitely going to improve. No one likes to talk about complications, and I'm paranoid. I think the surgery is the most, not the important part, but the preoperative checkup and working for it is important. We had 2 deep wound infections where we had to do a lavage with 5 liters and in anesthesia. We had several pleural effusions and pneumonia, but no aspiration pneumonia, which could be managed conservatively. Several cases of pancreatitis, particularly in curves around 90 to 100 degrees in the thoracolumbar junction. If you're doing a lot of translation, they have severe pancreatitis. Pressure sores, luckily, are very rare because of the use of air mattress. Ileus is almost always present post-operative. It's a mechanical ileus, so you have to wait sometimes up to 2 weeks. They need parenteral nutrition and a good intensive care. One patient developed a neuromuscular bladder voiding disorder and had to be discharged with a permanent vesicostoma. One patient developed a volvulus with resection of almost the complete small intestine. And in one patient slipped into status epilepticus. This was a patient who already had unstable epilepsy and was 2 months on the pediatric intensive care. We had one patient on the pictures on the right with Propionibacterium acne. I did a debridement in anesthesia with 3 to 5 liters of saline 3 times, then contacted the infection specialist and they said, stop it, it's not going to heal with primary closure. So we did regular dressings and over a period of 3 to 4 months achieved secondary healing. Luckily, the implants are still inside and there was no need to remove the implants. Late complications, rod breakages. I see less rod breakages because of my implant density, but we do see screw pullouts in the proximal or distal end. This patient on the top, you see, I fused till L4 instead of L5. This was in my earlier days with severe spasticity, and she managed to rotate her pelvis 30 degrees over the 2 disc spaces and needed an extension to the pelvis. This is another girl with cerebral palsy. She had a pull out of the last screw, but maintenance of the fusion, maintenance of correction, no loss of correction, so we left it. Because I fuse only the sacrum and don't use sacropelvic fixations, I do see asymptomatic osteolysis occasionally, but this has never caused any infection, and I have seen that after 3 or 4 or 5 years follow-up, the screws are anchoring to the bone again. We had one patient of late infection after 10 years with breakthrough of the implants, and he was severely handicapped, and we talked to the family and the family opted for extraction of the implants and no revision surgery. So the consideration for cerebral palsy and scoliosis are preoperative workup is essential, detailed consent with possible complications, consider evaluation of social and family setup, management of nutrition deficiency, epilepsy, and spasticity. We prefer, if there is a severe spasticity, to put in a baclofen pump before doing the scoliosis surgery, because patients with severe spasticity are catabolic. So it's very important after the surgery that they put on weight and they can have a positive calorie balance. I prefer to do hip surgery before the scoliosis surgery. After our one experience with Propionibacterium acne, we prefer to give the patients a beta-isodona soap bath or a soap shower preoperatively. And I prefer to give botulinum toxin to all hip muscles, both sides, at the end of scoliosis surgery to optimize postoperative seating ability and hip physiotherapy. Like mentioned from several speakers, you cannot run the circus alone. You need a lot of specialists, you need a lot of cooperation, and preparing for these surgeries takes sometimes 6 months, and it's like preparing for a marathon. But if they're well done and if they're well planned, these are the patients who they benefit the most from spinal stabilization. Thank you for your attention.
Thank you very much, Dr. Sarraf, for your nice presentations and sharing your experience in such difficult topics. Thank you very much. We'll continue for the next speaker, Dr. Walid al-Nawawi, a spine specialist from Alexandria. His presentation is recorded, and it's about the spondylolisthesis with scoliosis. Abdulaziz.
Assalamu alaikum wa rahmatullah. First, I would like to thank Professor Yusri Al-Hawari and the organizing committee for this distinct yearly event. Well, our presentation today is about spondylolisthesis in conjunction with scoliosis, and this presentation is prepared by Professor Ahmed Hassan Abu Alfa and myself. Well, let us begin with presenting some cases. I grouped our cases here into two subgroups, a post-surgical discovery one and a pre-surgical discovery. So the first group, a 29 years old female which suffered from late onset idiopathic scoliosis, and she was managed by the single rod technique 16 years ago. And this is her follow-up X-ray showing a solid fusion mass after the removal of the implant. Well, she came complaining from low back pain and right sciatica, and on doing spot X-ray view on the lumbosacral junction, we can see here instability evident, isthmic spondylolisthesis in L5S1 level. This is her MRI, and she was managed by instrumented fusion. Another 24 years old female, also managed with a single rod technique 15 years ago, and the current complaint was low back pain and left sciatica. This is a postoperative X-ray. Well, she had also isthmic spondylolisthesis, but the preoperative X-ray unfortunately was lost through the preparation. A third case is a 14 years old female. Well, she had late onset idiopathic scoliosis, and she was managed with a short segment fixation. And well, of course, after 2 years, adding on happened, and there was a progressive deformity, plus the complaint of the patient of low back pain and bilateral sciatica. Here, which can be misleading because what catches the eye, of course, is the progression of the deformity because of the short fixation. While on doing also a spot lateral X-ray view, we can see there is an isthmic spondylolisthesis which matches the complaint of her low back pain and sciatica. And she was managed by correction of the deformity and fusion of the instability. The other group, the pre-surgical discovery one, here's an example of a severe deformity case, 16 years old. And this is her X-ray view. Here we can see clear L5S1 isthmic spondylolisthesis. Another case, but an early onset scoliosis, 7-year-old girl. Well, the parents came complaining of the deformity that she had, and on doing the X-ray, closer view and the closer look on the lumbosacral junction, well, it showed also an isthmic L5S1 listhesis grade 1, which was almost asymptomatic. The main complaint was the deformity. This is her MRI. So if you want to group the cases of spondylolisthesis concomitant with the scoliosis, we can say that there are 3 main categories. The adjacent segment disease, where shifting of the stresses after fusion surgery into the non-fused spine, leading to the instability later on, or iatrogenic cause due to any destructive procedure which was done intraoperatively, or a coincident type, for example, like the dysplastic isthmic spondylolisthesis, which may be totally asymptomatic for a long period of time, and it may go unrecognized. And the treatment, it should be actually individualized, and each condition should be treated as a separate condition. So if the listhesis meets the operative criteria and the scoliosis not, then we do surgery for the listhesis and we follow for the scoliosis, and vice versa. And if both needs surgery, then do surgery for both, but of course with some tips and tricks. And if both doesn't need surgery, then observe and follow up for both. The operative indications for the listhesis, symptomatic, unresponsive to treatment, or progressive, high-grade slip if there is neural symptoms. Of course, the scoliosis has a wide list of indications according to the curve type, the age of the patient. So to summarize the recommendations proposed by Professor Ahmed Hassan Abu Alfa, as he has a big expertise in this topic, is that we should think systematically when we face a case with a deformity with spondylolisthesis. Each condition should be treated as an isolated problem, and we should always do spot lumbosacral views through the radiological assessment of the deformity. And if the spondylolisthesis happens above a previous fusion for the deformity, then we can extend few segments above, and if it's distal, then try to avoid contagious fusion down to the sacrum. Try to preserve few motion segments between the fused portions of the spine. Thank you very much.
Thank you very much, Dr. Walid. And as we are approaching the end of our 6 days marathon, I'm delighted to present our last speaker, Dr. Firas Al-Husban from Jordan. Dr. Firas is a spine consultant of spine, and he's the president of the Jordanian Spine and Pain Society. He'll talk about the OLIVE technique. It's an MDT symposium. Please, Dr. Firas.
Thank you, Dr. Sharif, for your presentation. And in the beginning, I would like to thank Dr. Yusri Al-Houari and Dr. Mohammed Khattab for again giving us the chance to learn from each other about the spine and in this esteemed event. I think shared now the slides.
Yes, Dr. Firas.
Just 1 minute, because we have just 1 minute. Okay. We will talk today about Olive surgery. And this is, we are talking about technique of a fusion rather than we are talking about a disease itself. So I would like to start with this case, and I would like to ask every one of us, if he sees a challenging case like this, what to do. So it is a 78 years old female patient. She has end stage medical comorbidities like, diabetes mellitus, hypertension, heart failure. She is about 145 kilograms. She is morbid obese. She cannot walk even indoor because she has a weakness in the lower limb, especially the dorsiflexion is 3/5, and she has also severe peripheral neuropathy. And if you see this MRI, you will see a lot of spinal canal stenosis, especially at the level of L4, L5, L3, L4. You see spondylolisthesis, L4, L5, reticulolisthesis, L2, L3. And if you see the patient is morbid obese. So what is evidence in the studies that old age, like 78 years old, and medical comorbidities, the meaning of this, a lot of complications after the surgery. So how to do this surgery with less complication? And this is the challenging case. So we will see the solution later on. So what we do in spine, whatever we do, even it is stenosis, degenerative, we have to do decompress the spinal cord or the thecal sac and the nerve root. We have to do sagittal balance. We have to reconstruct the spine, and we have to do good diffusion. And the concept is the fusion. If you have good diffusion, we don't have later on any complication. If we have pseudoarthrosis, we have another surgery. So how to do this diffusion? As we know, we can go from variant, approaches. As you see, we can go from posterior, from lateral, from anterior. So what the concept is to go from anterior. Why? Because in anterior surgery, the most important option, it is the large bone graft. So you can contact the end plates over the vertebra, and you put the cage, big cage with the bone graft. So the incidence of fusion is better, and you can also improve the sagittal balance, and you can reconstruct the spine in mechanical wise in a better outcome. So what about the posterior approach? As you see, we have a lot of muscles, we have facets, we have lamina. So you have to go through a lot of soft tissue and bone tissue to go to reach the thecal sac in the lumbar spine, or and to manipulate the thecal sac and the nerve root to go in the disc space and to do the fusion. And if you go from anterior, it's better because you go directly to the intervertebral disc. But if you go open surgery, you have to mobilize all the viscera inside the abdominal cavity, and it has a lot of complication. But if we go directly through the muscles and we don't manipulate extensively the organs around or the soft tissue, and we go through this window and to go direct to the disc space, we can do the surgery with less invasive techniques, with less soft tissue injury. If we go from L2 to L5, and in the L5 is when you go between the bifurcation. And this is our topic. Our topic about oblique trajectory of the spine from the lateral position. So if you see here, this is the MRI, and if you see, this is a psoas muscle, and this is the aorta, and this is the vascular window, we name it, between both, and we can go directly from this window, and we can reconstruct, and we can take the disc space, and we put our cage with a minimal invasive technique. So we will talk about Olive, and the objectives of this lecture. We will start about indication, advantage, instruments and setup, preoperative planning, surgical techniques, and complication. Indication, we can do as a fusion with Olive all the disease of the spine. So we can do degenerative scoliosis, we can do spondylolisthesis, non-unit pseudoarthrosis, adjacent breakdown, degenerative disc disease, even infection, and we can do revision with removal implants and reconstruct again. So what is the contraindication? There is a relative contraindication in this technique, and if you see this, osteophytes in the foramina. So it's hanging the nerve root when you distract the disc space, and you have then compression more the spinal cord. In this case, you have first of all to take the osteophyte off, and then to do the anterior lateral surgery and to do distraction over the intervertebral disc. So what is the advantage? As you see, this is the nowadays surgery. So this is the surgery that you see in this photo, and this is the outcome here with minimal invasive. So what we have less tissue damage, we have less bleeding. The dead space, there is no dead space. The infection is very, very, very low. It's uncommon. There is less neurological deficit. The operative time is really less, healing time, and the hospital stay is about less than 48 hours, and sometimes less than this, and the rehabilitation and going to the work early than classic surgeon. We have the instruments, the special instruments. The most important is the retractor, and now this is the old one and is more advanced and protecting the tissue. This is the instrument, like, you know, the to clean or to prepare the end plates, to take all the disc space and the cartilage from it, and this is the instrument to insert the cage and to prepare for cage position. And very important, the spinal cord monitoring. We do all the cases with the spinal cord monitoring, unless in the Olive technique you don't need it. You can do it without spinal cord monitoring, but we advise to do it with the spinal cord monitoring. And the CR machine is our fighter. So it's the machine that we can see where to put our cage and the position of the cage. So preoperative planning is the most important. So we have to see, as you see in the X-ray, is important still to see if we have high riding iliac crest and the lordosis. The lordosis is very important to see it in the X-ray, because it's giving the axis of the cage from down to up. And the MRI, as you see the vertebra, you see the aorta, you see the psoas, and you can go between and see how much is the vascular window. Sometimes we don't have a really window between the aorta and the psoas, so we go to the anterior tip of the psoas and we reflect it. The CT scan, if we have osteophytes and we are suspecting any osteophyte in the foramina or around, we do it. So this is the position, is lift up lateral position completely straight, and after that the CR machine. This is the key of the surgery. If you really find the end plates, as we see in this X-ray, in the AB and lateral parallel, and you see the both eyes of the pedicles in the AP, and you see the facets also parallel in the lateral, so it's doing the surgery very smooth and is getting up from the complication of the surgeon if he doesn't do the proper position, and you work as the C-arm is vertical over the table. So the incision, as we see, we are marking the intervertebral discs. We are going just 5 centimeters from the mid of the intervertebral disc, and sometimes you can go from the tip of the intervertebral disc is 1 to 2 centimeters, according how much the patient is obese or he is less or thin. The skin could be transverse and could be oblique, as the preference of the surgeon, or as how is the body of the patient to access the intervertebral disc. So what we do, just we open skin about 2 centimeters, then we go immediately to the external oblique muscle, and we do only stripping, and the other muscle, the internal spring, the same, the transverse, and we, with our finger, we go immediately in the retrotubulanar space. You can feel the iliac crest and go down to the transverse process, and you slip over the psoas, and then you go immediately to the vascular window, and sometimes you feel, most of the times you feel the aorta pulsating. And this is the technique. So you go stripping all these muscles, and you go to the aorta, and you put your finger, usually if in the vascular window, if it is not, you go to the anterior border of the iliopsoas. So as we see, this is the wound. This is 2 centimeter wound in this case, this is the L4, L5 I did before the L5S1. And this is the external oblique muscle, as you see. There is no real bleeding in this stripping. There is in this, you know, the olive, usually you don't have any bleeding. You will have some, you know, in your finger to see it, but you don't have any bleeding because you wouldn't have muscles in this stripping. After that, you see this is the internal oblique muscle. We can strip it and through the small incision. And after that, you can see the transverse. And when you see the transverse, the transversalis, you can see immediately the retroperitoneal fat. Now, this is the last layer. If you open this layer, you see the retroperitoneal fat. And if you see it, you go immediately with dissection with your finger. This is the video from my mobile, so it is not too much professional, but it's enough to demonstrate what we are doing. So, and if you see that this is the iliopsoas, this is the L4, L5, this is the retroperitoneal fat. So you go immediately in the vascular window, and we are here the aorta in this exactly and the vascular window. So what is our concern? Usually in the iliopsoas, it is the lumbosacral plexus. But if you see where we are going in the tip of in the vascular window, we are away from the lumbosacral plexus. And usually when we put our retractor, after that, with the spinal cord monitoring, we can see if there is any nerve roots in your approach. So this is the usual that we do. We open with our finger, then we do as a marker inside the disc, then we put our dilators, and after that we put the retractor. You can see there is usually, this is that we do usually every day, that we don't have any bleeding, we don't have any real injury of the vessels. Here with the spinal cord monitoring, we see if there is any nerve root in the field. So this is the tip of the iliopsoas. And after that, we open with the knife the disc space. And we use all the instruments that we show, and we clean all the disc. And after that, this is the cage. We put bony graft inside and we insert the cage. And about the complications, the early complications was most of the patient, especially in the transpsoas, not the oblique one, lateral fusion, it was the anterior thigh pain, and this is from the irritation of the lumbosacral plexus. But all the studies, there is no any permanent real complication from the lumbosacral plexus if you go in the proper technique. And I want just to show this paper. It's from 2016, and this is talking about the complication. This paper I selected because they did the for 812 patients, and the complications was from L2 to S1. It's not for the even the L5S1, it was in this study. And if you see even vascular injury, it was 0.24. Sorry, this is the bradycardias. This is the vascular injury is 0.37. So it's very rare and uncommon. And the infection, it was the same, is around 0.62. So the complication rate in these surgeries is very, very low and uncommon for a serious or major complication. About the anterior thigh pain is very less with the oblique approach, but it's within, even if you have it, because sometimes we go under the psoas and we reflect the psoas. If it is very big muscle, some patients, they have a huge psoas. So we have to go down to it and to reflect it and do our fusion. In these cases, we have anterior thigh pain, and paresthesia, but most of them at 3 months, it resolved. So about, you know, the L5S1 is the same technique exactly, but it has a different approach that we have to go between exactly the bifurcation and the aorta and the vena cava. And the preoperative MRI, we have to see the psoas and the bifurcation. This is the bifurcation, and this is the common iliac arteries, both right and left. And at the end, if you see that this is the external iliac artery, and there is, you cannot see it here, it's more right, and this is your approach. We don't have any vessel in front. So the approach that we designed, it is about 2 fingers below the iliac crest anteriorly. As you see, we open the skin in the L5S1. It's almost about 2.5 centimeter to 3 centimeter. It depends in the size of the patient, how much is he is, you know, and how much even the planning for the incision is very important to know how much the lordosis and where is the exactly the L5S1. This is the retroperitoneal fat. We open the external oblique fascia, and this is the peritoneal fat, and then we dissect even from up to down to feel sometimes the external and internal iliac arteries from the left side, and then you feel the vena cava, either common or iliac arteries and veins. And then if you see here, we put our retractors, and we protect the bifurcation of the aorta and the iliac arteries with the retractors. We can take the disc completely out like cervical fusion, anterior discectomy. So we take, this is completely clean in the blades of the L5S1. After that, we insert our cage. This is the sizer. See what is the proper size for the cage. And after that, if you see that this is the cage with the polygraph, and we insert our polygraph inside, and we can end up the C-arm. We see where is the position of the cage and the proper position for the L5S1. So this is the end of the surgery. And for the case when you have a very huge patient, and you know, with end stage diabetes mellitus, the problem is the wound healing, and then the incidence would delay wound healing, and this is more incidence for infection. So small wounds can clean more easily than the big wounds with the muscle injury. The most important in this surgery that you don't have muscle denervation and muscle ischemia and injury through the approach. So this is the case that we saw in the beginning, and we did the L5S1, then we did the L4, L5, L3, L4, and this is the incisions. And we, in the mid here, you see there is decompression of the spine by even minimal invasive. This is the lateral recess that you see, that we take the lateral recess from with the tube surgery, and we do the decompression, and this is the end stage of the surgery with the small wounds. And this is the surgery for obese patients. I would like just to show you some cases, which is revision cases, to know what we can do with this technique of a fusion. So this is the first case. This is a 36 years old male patient. He has twice open discectomy, and if you see the MRI, there is, you know, laminotomy with facets degeneration, and this is the collapsed disc with foraminal stenosis. So if we open and distract the disc, the foramina will open, and we will not have any compression over the nerve root. And this is that we did. We go with the olive, and we put our cage with distraction, and then we put our screws, as you see, from the percutaneous, and this is the end of the case without really to going inside and to have adhesions, and to take the adhesions from the thecal sac, and to go to reconstruct the spine from the back. In the cases of spondylolisthesis, we have a lot of cases of spondylolisthesis that we did in this technique till grade 3 to 4. And this is a grade 2 spondylolisthesis. This is a 55 years old female patient. And this is the, if you see that there is L5S1 symptomatic spondylolisthesis for fusion. So we did in the same technique, and we, if you distract or indirect distract the disc space up. There is ligamentotaxis from the anterior longitudinal ligaments and the posterior, and the reduction will be excellent by distraction only of the disc space. And this is the post of X-ray, as you see. And this is the wound, and this is from the back, and this is the surgery for spondylolisthesis by minimal invasive technique or by oblique surgery. This is revision spondylolisthesis, and this is the spinal canal stenosis of 45 years old female patient with intermittent claudication of less than 50 meters. This patient from Philippines, I did this in Dubai, and this patient did the history of a tumor surgery before 23 years. And when she came to me, she had L4, L5 spondylolisthesis, as you said. The problem was, the spinal canal stenosis at the 3 levels below, as you see. And this is, in the CT scan showed that all the capsule of the facets was calcified. So what to do in this case, that we had to go to reconstruct from anterior and posterior. What I did, it was helped me a lot, the OLIF surgery. From the beginning, I went from the back. I did decompression by fascectomy and laminectomy, and I did by screws from the back, as you see. And there was, the L4, L5, it was calcified, and I did the osteotomy. And then I went from the lateral position. I put L5S1, L4, L5, L3, L4, and this is the end of the results with less extensive, because if you want to go from the back, it will be very extensive surgery to mobilize the thecal sac and to reconstruct the sagittal plane of this patient. This is a case of scoliosis that we do sometimes because of the lumbar scoliosis from the anterior is very easy to correct it in a rigid scoliosis. So what I did OLIF techniques for the last 3 levels, and I saved the L5 level, and then I did, as you see, by minimal invasive technique, the thoracic spine, and this is the ones. This is percutaneous because we did a very good cage from in front, and we opened also minimal invasive, and we did fusion from the back. To avoid major surgeries, this is a case that I did. This is a 34 years old female patient. She has a fusion from L4S1 before 3 years. And then if you see there is broken screw, the L4, L5, there is pseudoarthrosis. And in this case, if you see the MRI, the L5S1 is very well fused, and the L4, L5, it was, if you see dynamic fixation, that's why the pseudoarthrosis. So that's why I broken the screw. What to do? We have to take the screws out and to go from the back and adhesions and so. But for me, it was the OLIF is the solution, one of the solutions. So we just did the OLIF technique. We distract the disc space. We put a very good bone graft and with the bone morphogenic protein. And this is the patient. This is the wound only of the surgery. We didn't touch the screws, and this is the patient only after 2 months of the surgery. So we have also the problem that we know from fusion surgeries, which is the adjacent level recurrence. And this is one of the cases that if you see that she has, adjacent recurrent level, and what we do, if you see that there is spinal canal stenosis at this levels, so you can insert only the cage in this level with bone graft, and I have more than 15 cases that I did in this technique, and we don't have any really real complication except of one. We have pseudoarthrosis, and the other 9 it was with good fusion. The revision TLIF, we can take also, this is case of pseudoarthrosis, as you see, and there is no any compression over the thecal sac of the spinal cord. It's only the pain, the axial pain, and from the pseudoarthrosis. And what if you see that also there is screw loosening, and through the L5S1 in the same technique, as you see, we can take, this is the cage, and the cage is moving inside, and after that we take all the cage outside from the L5S1 with the small incision about 2.5 centimeter. We prepare the disc space. This is the cage that we removed, and this is the cage that we put, big cage with bone graft, and this is the incision that we did for the surgery. And this is the end result. The last case is about to do revision also scoliosis. In this case, this is a 49 years old female patient. She has adult scoliosis, had surgery before 8 months. And she came to us with severe low back pain. I would like to show you the first presentation with my colleague. He did the surgery. It was real difficult case, a very fixed spine. And she came with severe pain with the deformity degenerative spine. What did my colleague? He did the correction and the fusion for the surgery, but you know, the problem in these cases, the pseudoarthrosis. So what happened if you see that, you know, the loosening of the screws, especially in the S1 and the L4, L5 screws. When we did the CT scan, you see the S1, there is also not loosening only, but the end plate also is fractured, and the L4, L5 is the same in the CT scan. So what to do in this case? First of all, we have you know, to do good diffusion in this area, and if we do good bony graft with reconstruction at the 3 levels, I don't use sacroiliac screws more because of the complication of sacroiliac screws. So what I did, I went from the in front, I took the L5S1, I put my cage with the plate, and this is a plate, you can put it whenever you see there is instability in the same wound by the same instruments. So this is the cage. The L5S1, it was collapsed. I put also cage in the L4, L5, and the cage in the L3, L4, which giving me, you know, the sagittal balance, if you see there here. So it was flat back, and now is the sagittal, and we secure the fusion in this area. And I correct also, I removed all the screws, and I did the correction of the spine with preserved sagittal balance and pelvic incidence. This is the surgery was, and this is the surgery after. It helps you a lot, you know, to reconstruct the sagittal balance in these surgeries, the anterior surgery, and the, mostly by minimal invasive technique and by olive surgery. So this is the last case, and thank you very much for listening for my lecture.
Thank you so much, Dr. Firas, for your participation in our activity. And thank you so much for highlighting the importance of mastering anterior approaches as well, because sometimes it may help the spine surgeon to solve unsolved problems. And by this presentation, we reach the end of our marathon, as Dr. Sharif Al-Ghamri said. And before closing remarks and hearing from our great mentor, Professor Hawari, and my dear brother, Dr. Sharif Al-Ghamri, would like to open for discussion and comments from the panel to the last speakers. May I start with Professor Firas regarding managing the patient with this patient with obese, really obese, 145 kilograms, and you approach this huge belly from small wound. Is it really easy? I feel that may I need access surgeon to open bigger wound and to approach the spine?
Yes, you know, this is the concept of minimal invasive technique, and the minimal invasive technique is very suitable and convenient for obese patients. So what's the difference between obese patient and, you know, thin patient is the length of the tube. So in this case, I have a tube of 16 centimeters. In some patients, we have 9 centimeters. So what is the difference? Is the same tube, and the same diameter of the tube is going, but it's the length is different. So there is no any difference between thin and obese, because if you put the patient in lateral position, all the abdominal cavity will fall down to the right side. So it will be away from you. So if you go with your finger, you will reach the psoas even, and you go down. So you don't need incision more than 2 centimeters. And that's why, you know, this technique, or the minimal invasive in general, in all the concept of minimal invasive, because I do in all my surgery minimal invasive technique, it's helping a lot in obese patient, and you don't have dead space, you don't have hematomas, you don't need drain, you don't have bleeding, and this is the concept to be more, smooth with the soft tissue around.
Dr. Faraz, did you try this Olive technique in adolescent idiopathic scoliosis? I mean, to correct the lumbar curve and the thoracolumbar curve, the rotational deformity by anterior approach, minimally invasive approaches. I know you do minimally invasive surgeries for AIS from posterior, but from anterior, did you try it?
Yes, I showed you, one case that I did the lumbar spine by Olive technique. I put the cage from the back and from the anterior, and from the back I put the screws. And usually when I do this, the patient immediately, it's in the hospital only 48 hours. And the patient came after 1 week walking very well with less pain, and he can control his body very well. And they go to school within 3 weeks to 1 month. And this is the concept. Yes, I do. And I do something else, that sometimes I don't use the cages, but I go with small incision, like as example, 2 to 3 centimeters, and then go with the tube, and I take off the annulus fibrosis with sometimes the concave side, which is the contraction of the annulus fibrosis, which is the concept of rotation. And if there is also anterior, I take some part of the anterior longitudinal ligament, and this is helping a lot. When you go back and do fastectomy, you don't need real osteotomies. It's the rotation will manipulate very well with you. So the concept of rotation, usually it is from the facets and from the annulus fibrosis from the anterior. So if you don't want to put cage, it's a very good approach to release the spine from the lumbar spine, to reach the lumbar spine from the annulus fibrosis, and even sometimes the anterior longitudinal ligament.
Faraz, it's a great presentation. Hi, how are you?
Hi.
Could you tell me, how do you fill the cage, this big cage, and how do you prevent the bone graft from falling when you're hammering on the cage?
Usually I use the bone matrix, which is paste inside the cage. So sometimes if you go from the lateral, in the L5S1, there is no way to go outside because it's spaced and as the cervical fusion exactly. It's a very easy surgery and less traumatic as you do cervical fusion. This is L5S1. The only dangerous that you are going between the bifurcation, and this is that you have to have with you vascular surgeon, and it's a learning curve. But the L5S1, there is in the instruments, there is 2 plates covering the cage. And when you put it inside the end plates, the cage is going inside, and the plates that protecting the bony graft is going back. So you don't have sealing even if you want to put bony graft from the cage itself.
Dr. Vinay,
previous speakers?
Dr. Vinay, may I ask you regarding managing spastic patients? What is the correction techniques that you rely on while correcting the spine deformity in these spastic cases?
Basically, it depends on which system you're using. I prefer to use polyaxial screws. I hardly use uniplanar or monoaxial screws in neuromuscular cases because I like to have the system a little forgiving. I prefer to also use a very high implant density and usually rotation maneuver or translation, however, depending on the curve of the patient.
So rod rotation and translation.
Translation, but mostly rod rotation. And it's if I can get the curve to 40 degrees, I don't try to correct anymore. What the patients basically need is stability and balance. And it's not like idiopathic scoliosis where you say, okay, I will derotate, I want to remove the rib hump. They are young children. These patients just need stability.
So you work within the flexibility of the curve. You just do some release by fastectomies and work with the flexibility of the curve.
I do a very radical release. It's very important. I think it's better to take 2 hours for a for a proper release, remove the disc, remove the interspinous ligaments, resect the facet joints properly, and adjust the margin of the facet joint, mobilize each segment, and so you have less load on the implant, and after that you also have less screw pull-outs. So I think the approach in spastic or in neuromuscular scoliosis is the most important, because you're dealing with pathological bone, so the less load you have on implants, the better the implants are going to hold.
You use the convex rod first or the concave rod, or both and simultaneous
Both.
rotation?
I put in both and try to do a simultaneous rotation.
Okay, great.
Yeah.
If there is any questions?
Can I ask Dr.
Yes,
Saraf a question, please?
Please, Dr. Raf.
Actually, it's a big dilemma with me. When do you go for surgery in cases of Duchenne myopathy? Do you depend on the curve? Do you depend on the age? Do you depend on the ability to walk, or weakness in the degree of weakness in lower limbs? When do you really go for correctional scoliosis?
Usually the scoliosis and the spine starts decompensating when they lose the ability to ambulate. So even if severe Duchenne patient, they are usually walking between 7 to 8 years, and once they start sitting, I usually take a X-ray follow-up every 6 months, and in this time they also go to the cardiac and the pulmonary outpatients. And I have operated Duchenne patients who had maybe 20-degree scoliosis, but the pulmonary physician said, okay, he has started decompensating from his lungs, he has started decompensating from the heart. I explained to the parents and say, if you wait for the scoliosis to be 40 or 60 degrees, the cardiopulmonary risk is so high that you can't perform the surgery. So I'm quite aggressive, and if the family understands the situation, they are the ideal patients to manage. Like the
So the
patients
main
which I showed you.
indication is the deterioration of the respiratory function.
Yes, in my opinion, yes.
Okay, thank you.
Thank you.
So
We have a
thank you so
question
much.
for Dr. Firas.
Yes, please.
From Ahmad Gabr. What could secure avoiding injury to the lumbar plexus during operating olive technique without nerve monitoring, especially with we needed traction? Dr.
Yes,
Firas.
thank you for this very excellent question. Look, this is the concept to do that. If you see that if you do, as example, compression in any muscle, you have to finish your job before half hour. So the procedure to do this fusion, it takes usually 15 to 20 minutes over the iliopsoas. This is the problem that we have. Some patients, they have a huge iliopsoas. Really, you see that the iliopsoas taking the spine till the mid. So you have to take the anterior tip of it and to go down to the iliopsoas and to reflect the iliopsoas. And in these cases, usually you don't injure. If you have ischemia over the muscle, you have inflammation over the sacral plexus. So never ever you have injury. But what you have ischemia time, you have inflammation, and you have some pain over the anterior thigh and paresthesia. And usually in all studies, there is no any permanent sign or symptom over this. It is 90% of the patient, more than 90%, they will resolve within 3 months. And after 2 years, no any patient have any pain or paresthesia over the same.
Okay, over the last 6 days, we enjoyed a lot. I learned. I'm organizing this event with Professor El Hawari and my dear brother, Dr. Sharif Al Ghamri, since 5 years. And for these 5 years, every year I learn something new. And this year, we run 11 webinars, 52 faculty, 32 international speakers, 19 national speakers. We are have friends and colleagues from more than 20 countries. I think it is achievement that we're in every day more than 5 hours daily for continuous 6 days. I'd like to thank you all. Without your support, we couldn't achieve this event, and the success will become in the future when we find good surgeons and good generations following the tips and tricks that they learned from this week. And I'd like to thank the founder of the Egyptian Scoliosis Society, Professor Al-Hawari, and I like to hear from him his impression at the end of this marathon.
First of all, I would like to thank the attendees for keeping us with us all the 6 days, and then I would like to thank all the faculty and all the speakers for their great work and the time they put in their presentations. And I also want to thank the sponsoring companies who helped us to bring up this meeting, together with the organizing body, the COB, the Conference Organizing Bureau, for their work, and especially Abdelaziz for putting all the pre-recording meetings and talks. So thank you, everybody. Thank you, Dr. Khattab really did a great job. Thank you, Dr. Sharif Al-Ghamri, and thank you all. And hopefully next year it will be a physical Scoliosis Week with hands-on and scrubbing in the scoliosis cases like we did in the first 3 Scoliosis Weeks. So thank you, everybody. Have a nice day, night, and see you next year. Goodbye.
Inshallah.
Thank
Shukran
you all.
jazilan. Thank you so much.
Thank you so much.
Thank you so much.
الله يعطيك والف عافيه.
الله يخليك.
أبداع.
خلاص.
حبيبي
راسنا.
نفتخر باللي بتعملوه صدق وامانه.
الله يخليك.
Shukran, Dr. Farash. Shukran, Dr.
حبيبي
Wafa.
محمد.
Thank
Dr.
you so much, Vinay, for your participation.
You're welcome.
It was an
It was a
excellent,
pleasure. It was a
an
pleasure.
excellent presentation. Thank you so much. Thank you all. Assalamu alaikum wa rahmatullahi wa barakatuh.
Assalamu alaikum.
Goodbye, everybody.
Bye.